Hello and welcome to the Institute of Healthcare Management's series, really, where we're going to be talking about health managers, how they work with digital technology, and how they can make the most of the many opportunities that digital health technology provides. This event is in collaboration with the Giant Healthcare Exhibition and Conference, and we are delighted to be partnering with Giant. I have three of the finest brains on the planet to join me today to talk through these various different topics, and I'm going to leave each of them to introduce themselves. So, Michael, would you begin, please?
Thank you, John. Yes, my name is Michael Morgan Curran. I guess you could say I'm an experienced health technologist. I've been involved in health technology proactively for about the last 15 years. And prior to that, in its very nascent form, when I used to be part of the pharmaceutical and life science industries. I think for the last 10 or 15 years, I've seen a huge change in technology development. And along that journey, I started a couple of startup companies myself, which unfortunately have failed for many different reasons. But a few of them are doing quite well at the moment and quite successful. One in particular called Hearten, which is an ECG company, which we started up earlier last year. So that's me.
Thank you, Michael. I'll come to you next. Shane, please.
I'm Shane Tickell. I'm CEO of Temple Black, and I've spent nearly 3 decades in health and technology, and really around the electronic patient records. And my mission is to try and bring data from conception of life through to end of life care for direct real-time care for individuals, for population health management, and real-world, real-time data for research, so that we can improve everybody's journey. And that's pretty much my focus.
Thank you, Shane. And now Hassan.
Thanks so much. I promote the UK health sector abroad on behalf of the government department, the Department for International Trade. I'm a former entrepreneur, so I set up a company in health analytics and had an exit in 2019. Before that, I was a social worker and NHS analyst in public health informatics and commissioning.
Fantastic. Thank you, Hassan. Well, look, gentlemen, the topic is fairly widespread. I mean, we have a huge portfolio of interest here that we could go at. But what we're trying to do is to help health managers working in health and social care today to feel confident and comfortable about finding and evaluating, adopting and sharing and integrating technologies to do with health and social sciences and so on across the horizon. So, Michael, if I could come to you first, let's start with the first basic question. How do we help managers in health and social care to find and evaluate technologies that they think might be useful to them?
I think the single biggest challenge they have is, where do they start? Where do they go to for information that will help them identify the kind of problems that they want to solve. I've come across the situation quite a few times where healthcare managers that I've worked with are usually trying to fix it with the wrong kind of technology, or indeed they haven't fully scoped out the detail behind the project that they want to evaluate, and they're not quite sure who within their own local network they can approach to for that level of support. And there are bodies locally within regions which have been very successful in helping stakeholders, like you've mentioned, build potential solutions and services. One particular organisation would be the Academic Health Science Networks, whose primary role is to bridge the gap between NHS stakeholders and healthcare managers and potential industry partners.
Thank you very much, Michael. Great start here. Shane, do you have anything to add there to what Michael has just?
Michael started us off really well, hasn't he? And I would say, of course, find a special interest group. And I might be stealing some of the show, John, because I know that the IHM has just started a special interest group around digital. I do think talking to your network, and Michael's hinted at that, start with the people that you know and respect, and actually search out the people that you don't know. There's an awful lot going on in the UK. Over the last 25 years, I've been responsible for thousands of contracts And of all the technologies that are around, that pretty much everything that you need exists and is working somewhere today. The needles in the haystack are which ones are the good ones, and it's going to be about talking to them. One thing I would say is, don't just look at the ones that have sold the most or the biggest brands that have landed here over the last 10 years. There's an awful lot of really interesting stuff. But equally, Michael's hinted at, AHSN's a really, really good resource. But what we found over the last 18 months is the foundation of NHSX, and I think it's still finding its feet, but it is a new body and it is doing some really innovative stuff. I have a role as a vice chair on the Tech UK Council, representing about 185 technology companies of all sizes, small and large, and we really are doing a lot of interaction between NHSX and somewhat NHS Digital as well to try and get our knowledge known in both directions. So NHSX is doing some quite interesting things about promoting different capabilities, and I think that's probably not a bad place to go. Special interest group, talk to your neighbours, have a look at what NHSX is talking about.
Thank you, Shane. Hassan, I'm going to come to you any second, as you must have deduced by now. Do you have anything to add in to what Michael and Shane has started with?
So two fantastic answers. The first thing, and I think Shane's already picked up on it, is a bit of a Blue Peter job, right? It already exists. Almost everything that you'd want as a health manager has already been made somewhere, developed somewhere, procured somewhere. So all you've got to do is find out two things. One, who else has a similar challenge to you? And second, how have they solved it? And when you break it down to two very simple questions, it's less pressure. It's far less stressful. Because I think a lot of people get very worried when they hear digital, and that's not always the right way to start. So I think Future NHS, which is a fantastic collaboration platform, it now has, I think now 140,000 users on it. And the data analytics workspace has 12,000 analysts. I mean, there's lots of different workspaces on there. You'll find special interest groups. You'll find areas for collaboration. People want to help. So just try and work out who else has done a similar thing and how they got on.
I think that's a fantastic answer, and it would be remiss of me not to mention the IHM sister organisation, the Academy of Fabulous Stuff, and all that they do to highlight the brilliant stuff, best practice that's going on in health and social care. And I know that they have a number of digital health technology solutions. To use your expression, Hassan, find other people that have got the same problem, because guess what? Otherwise, we all run around trying to reinvent the same wheel, which doesn't really serve any immense purpose. Can we talk about the thorny issue of how we brief and explain properly what it is that we're looking for when we're actually exploring the market for solutions to particular challenges that we may have? Whenever I've looked at this in the past, where we've been doing reports or analyses or insights, this business of how do we help managers in particular to properly explain what it is they're looking for seems to be a particular, dare I call it, challenge that we have. Any thoughts around this? And I'd love to change up the sort of the order that we do things. So I'm going to come to Shane first this time. What should we be doing about that? Where can managers go to find how to do briefings, explanations, tenders properly?
Well, great question, John. I think first of all, what we should encourage is people to look at what's the problem. What is it that they want to achieve? What's the opportunity that they're trying to look for? So quite often we find in industry that people are looking for, I need a product that does electronic prescribing, or I need a new electronic patient record. Actually, I think there's a bigger thing now, and I'd like to think in the UK, as in England particularly, we're moving towards integrated care systems. There's 42 areas of the country with population between sort of 1.2 and 1.8 million. So those managers that are in there, what is it they're trying to solve, and what do they share? And is that, at what space are they coming from? Is it acute, primary care? Is it care homes? Where is it? And we need to have a look at what information is available, because frankly, there might be solutions that are already there, they just don't know exist. So they are going to have to reach out to their network, or they probably have a really good understanding. And then, as Hassan mentioned last time, going to talk to people who might have already done it. So it is going to take a bit of research. And I think there's three problems. One is people have got legacy things that aren't probably up to the job, or there isn't a system that exists. Then we've got fairly well-known solutions, and that's where people think, I need a particular product from a particular company. And actually, I think it is more about what are we trying to achieve? What do we need the information for, or the technology for? Where is it that we're lacking? And the more that we talk about that and ask the question of people in our networks, the more people will willingly come forward with those answers. And again, I'll support what Hassan said, the future NHS work. I've learned this afternoon how much that has grown. That's just phenomenal.
Okay, thank you, Shane. Hassan, may I come to you next? Same question, how do we help managers to be confident about building briefings, tenders, that kind of activity?
I think this is a classic business challenge, and I don't think it's about digital. It's about really understanding the heart of the problem. So let me give an example. Imagine that you are part of a trust and you've got lots of referrals coming in. Now, the problem that you could brief somebody on is, I've got lots of referrals coming in, how do I deal with this mess? I don't want to get a couple of band twos trying to fix all of these rubbish referrals and try to work out where they should have gone right. Somebody might say, here's some robotic process automation, which is going to solve the mess for you. And because you brief them, you end up with a robotic process automation solution. But if you shifted it to say, how do we stop the referrals being bad in the first place? You might have ended up with a solution that triaged your referrals at the front end. And therefore, it comes down to being very simple about the problem. Who is it hurting? Can you define it? Can you quantify it? And then giving that to a group of people to say, hey, well, can you bid for this? What do you think? And then looking at what comes out of it. So I would simplify it, take away the problem that people feel, with digital. You don't have to know what robotic process automation is or AI is. You just have to know, look, my referrals are bad. Why is that?
Do you know, Hassan, you speak such complete sense. I'm not suggesting for one moment that Shane Tickell doesn't, but that was a wonderful answer. This idea of simplify it, it's not necessarily the problem that you think you've got that you should be addressing. So thank you for bringing that one up. Michael, I've got to let you have the final word on this question. How should we be helping managers to think about issuing briefings, tenders, that kind of activity?
I think there needs to be a more coordinated approach in helping these managers, you build up, their knowledge and their experience, because at the moment they're just left floundering on their own, As Hassan said, the task of maybe fixing a problem or developing maybe a piece of technology around service improvement, something like that. But they don't necessarily have the core skills, and the knowledge to do that. So I think, some kind of mentorship program or some kind of internal training resource would be useful just to bring up the basic level of skills that would support people. And I know in the Institute, we can support them on that too. And just as people will be attending the giant conference over the next few days, online, they'll be able to meet with technology providers, digital transformationists, to get a better understanding of what they could potentially do. And it will also help them prioritize the kind of solution that they want. So Hassan was absolutely right. I mean, I've come across scenarios where I've received an RFP for a solution, which in fact never went anywhere, because really what the healthcare provider wanted was something completely different. And so scaling it back to what the real problem is. A classic example area with that in mental health, where we were asked to come in and provide some digital services, and that's what the service implementation managers wanted. And indeed what the CIO wanted, for that organization. But when it boiled down to it, they weren't even able to implement any of those services because they haven't got the basic infrastructure ready in order to design some of those or maybe implement some of them locally. So I think that's the real skill gap, I think. And I think that's the immediate need, I think, that most people have and most people want.
Shane, you've got thank you, Michael. Shane, you've got your hand up to add something else?
Yeah, just a couple of bits, really. I mean, there's no harm in market engagement. And rightly, as Michael says, over the course of the giant conference, there will be a lot of examples. And I think not just market engagement, but also speaker engagement. And I've found a lot of people make approaches after conferences directly, and they just ask for advice. And I think the more people that they talk to, the more they'll learn about networks. There are, of course, networks for people in specialist fields. They're probably already in them, like chief information officer networks, chief nursing innovation officer networks, chief clinical information officer networks, and they've grown really rapidly over the last few years. And also, I think I've long called for an idea of collaboration between industry and the NHS, and I would say it would be in the NHS X space now, for a centre of excellence, actually, so that over time we can share great examples like the ones that we do on the Academy of Fabulous Stuff, but categorise them into a way in which that people can absorb them and can share in both directions. Because frankly, industry is really interested in finding out those problems too, where we can complement and where we've got a weakness or where we've got a gap. And that's when I was sort of encouraging earlier, not just to go for the names that you might just have heard of. There's some fabulous solutions out there, but and they're looking to scale as well. So I hope that adds a little bit to the question, John.
It does, yeah. I'm going to sum it up, if I may, the answers to that question. I think, first of all, keep it simple. You know, don't try to overcomplicate something or simply respond to the first perceived problem that you come across. Take it back, pare it back as to why that is the case in the first place. And the second thing is, for heaven's sakes, don't try to do it on your own. You know, find colleagues, peers, mentors, experts, find them, involve them, enthuse them, get some effervescence going between your team members, and you're going to be in very good shape to take it forward. All right, let me ask another question. People talk a lot about interoperability. I suspect that all of you watching this, if you're involved in managing health and social care organizations and you're contemplating some kind of digital health solution, lots of people will have wagged fingers at you and talked to you about interoperability. The big question is, what on earth does it really mean? And how can you reflect what you're being asked in the solutions that you seek to procure? So Hassan, may I come to you first this time? Help the managers who are watching this understand what interoperability means, and more importantly, what should they be doing about it?
Okay, great question. So I had to travel to the States, pre-COVID, and I had to take an adapter. And the reason why I needed that adapter is because none of my devices would work without the adapter. But once the adapter was there, they could talk to each other. There was a fit, and that's all interoperability is about. And I think interoperability is actually just a symptom of a wider problem, which is fragmentation, because we never thought about this as being a joined up system from the beginning in a digital sense. So one hospital had 114 systems that didn't talk to each other. And then the ambulance systems and the community health systems and the primary healthcare systems were all completely different and not talking to each other either. And if we'd thought about it from the very beginning, like landscaping a garden, where do I want these things to go? Then it would have been fine. So if you're a healthcare manager, realize that you're in a system which overall isn't talking to each other. Are you going to make the fragmentation worse? That's the question that you have to ask yourself. And if you think that you've got the leverage with the CIO, CFO, and others to say, no, let's try and make this work long term, great. But if you have to solve that problem there and then, and it's going to create a bit more fragmentation, and everyone accepts that, fine. But don't get hung up on interoperability. Think of it more about, how do I join things up, make things work, people and systems working together. If you can make that work, then you've done a good job.
Thank you, Hassan. What a wonderful start to this question as well. Michael, may I come to you next up? Same question applies, really. Your observations?
Yeah, I mean, I engaged with the NHS many years ago when I worked with a telecommunications giant around the subject of interoperability. And it's only gained ground in the NHS probably in the last couple of years, where people have recognized, just as Hassan has stated, what the gaps are. So, in order for us to address interoperability, we need to have a standardized way of exchanging data and information across systems. And we have to make those systems, enable those systems to do that. All of us have experienced that in our daily work, where, we can't get a data sharing agreement in place, and we can't get visibility of different data sets, or indeed we can't implement a piece of technology because it's not interoperable with the system, you know. And in our healthcare managers, as they're moving forward developing their systems, will go through this experience. But you know, the chief information officer and, you know, the relevant transformation officers within the organization should be able to help with that discussion, because they're having that at a strategic level. So they should be able to help maybe solve or address some of those issues. And it may well be that there's some interoperability standards which are being developed, which indeed our healthcare managers aren't even aware of at that stage. But you know, it's, you know, the thing about interoperability is that it's relatively easy to fix if you have the right stakeholders involved in it.
Thank you, Michael. All right, Shay, I can see you grinning away there. You're clearly champing at the bit to put your penneth into this. Come on then. Interoperability, discuss.
I suppose it's because I hadn't realized when I started on this journey of information 25 years ago that that's what I was trying to do, was actually the surface of information. So whether it's interoperability, integration, whatever it is, actually the problem we're trying to solve, or the opportunity we're trying to take advantage of, is the information that clinicians need, patients need, and their carers need at the point that they need it. And the safe way of doing that there's got a governance involved, and you haven't got too much sensitive information, but you've got enough to do the job. And it's incredibly acute, lacking of interoperability today, especially with COVID. And so, yeah, I've been trying to sort of work on this for 25 years. And it stems from my own experience going through end-of-life care with my father, who was supported by so many agencies of hospices, acutes, GPs, community nurses, and our own family. We didn't share information 25 years ago. If we were lucky, we got a little bit of paper, but it was mainly phone calls. So in that time, and Hassan mentioned this, there's all these silos of information. And I think Michael's made a really good point as well. To me, it doesn't have to be perfect. What it has to be is good enough. And then you improve upon it. Now, there are some great examples. There are some initiatives of the last couple of years where we've created longitudinal healthcare records in certain parts of the country. They're using different types of technology. The simple thing would have been, if 20 odd years ago or so, we would have sat down and said, hey, let's all speak the same language. About 10 years ago, people said, why don't we standardize internationally on something called SNOMED CT? And there have been different forays to do that. Indeed, we've been involved in, my team that helped found Interopen in the UK to get industry to come together, because we were a little bit frustrated with the public sector, mainly the NHS information people coming together and getting this all to talk. I have to say that we're even still frustrated with that. So one of the initiatives that I would promote in London, which is a phenomenal, One London is looking at the whole information piece. They've done some great work over the last couple of years. They've got several solutions. One is called the Data Discovery Service, which is absorbing information, cleansing it, normalizing it, and then repurposing it back to the people who need it, alongside some out-of-the-box solutions from some rather big industry players. But overall, they're now supporting 9 million people or so in London. They're supporting things like NHS 111, the ambulance service, the GPs, the acute hospitals. They're all able to dive into this type of information and start to look at it. Now, I am going to say there are several different types of system, and there's several layers. Some people just scrape the information, present it, and you can look at it, but you can't do much with it. There are others who are really trying to move the information around and use it as a byproduct for predicting what's going to be needed for population health or for resources as well. So longitudinal healthcare records, is about 8 of those across the country. Some examples that have been in-house built, like the Great North Care Record, an amalgamation in London of different systems. And there are at least 6 other examples. I think one of the big things that's coming for us this year is Matthew Gould, the CEO of NHSX, has laid down a challenge that by September 2021, he wants to see the formation of a shared care record for everybody in the country. And there's going to be a lot of work over the next 10 months or so to try and make that happen. Not exactly sure what it's going to entail, but I hope what it does is it raises the standard for everybody. And so interoperability as such shouldn't be the challenge. I think it's about, what have you got? Where are you starting from? What do you need? And how can you get there? And then it's going to be coming on forums like this, coming to conferences, talking to the AHSN, talking to industry, listening to the bodies like NHSX and NHSD.
Thank you, Shane. All right, gentlemen. So we've kind of nailed the first two topics, but then the horrible dawn of realization breaks on one of our managers within the Institute of Healthcare Management that actually everything's been agreed. And you know what? We're ready. The procurement things have been signed, and it's going to arrive, whatever it is, a fortnight on Thursday. And now you've got to implement it. And now you start going to talk to people who you've briefly discussed it with, perhaps as a project stage, and you see the terror in their eyes as the realization breaks over them that this is new, it's going to involve a substantial change, and they are not really confident about your ability to make this happen properly. Because let's face it, there have been hundreds of examples of catastrophes where things have been poorly implemented. Discuss. Michael, how do we help people to go about this planning process so that they're actually confident about their ability to implement digital health changes properly and appropriately? What would you recommend?
Goodness me, that is a big question, isn't it? I mean, I've seen it done poorly, and I think the biggest success is pulling together the right stakeholder team, and making sure that they sit down very carefully and plan at every stage of it, and make sure that they establish what all of the risks are right from the get-go. Now, I know in the NHS we're pretty good at risk stratification, but you should always plan for the risks of the risks, to be perfectly honest. I would advise them, if they feel that there's a level of competency which they're not too comfortable about, speak to the stakeholders, because they may take on some of the implementation responsibilities as well, and maybe carve out some specific leadership roles within that too. There's no reason why they can't speak to agencies that have been doing this already. Engage with your AHSN, engage with your local university that's been supporting digital innovation, engage with your local hospital that's been driving some, digital transformation strategies. Learn from them, as to how they've done that in delivering a cohesive, project plan. And make sure that you refer to as much, online mentorship as you possibly can.
Thank you, Michael. Okay, so the big message from that is, for heaven's sakes, gather a half decent team around you in the first instance. Shane, anything to add to Michael's points?
Yeah, we've done some rollouts where we've gone live with sort of 4,000 people at a weekend. We've done that several times across maybe 15 sites across an entire county. I would say first, go and talk to somebody who's done it before. I always felt, we did this, actually I've done this in multiple sites in different parts of the country at the same time. And the fear is 90%. And like with a lot of good things, it's like baking actually. Get the ingredients right and prepare everything. And then the cooking's actually not too bad. I mean, there is a bit of tension, the week coming up to the event. And then I'd say the 10 days afterwards. Now, there's usually something that you didn't think of. You'll have missed something. But I think the best preparation is go talk to people who've done it before. Don't try and think, don't think you're the only people who've ever done this, because you're not. The people I find who have the biggest challenges after they've gone live is because they didn't go and talk to people. And an example of that would be somebody who redesigned their emergency department, their A&E. And they actually came and spoke about it 18 months later and said, gosh, it was so hard and we took so long and things didn't go great, but we redesigned every aspect of it. I said, great, who did you talk to before you did it? And they said, nobody. And I thought, there's 140 other ED departments in the country, and you didn't speak to anybody who's done this over the last 10 years. And I think that's why it was hard for them. So my thing is, go and talk to people, even if you don't know them, who has done this before. Do take advice. There are agencies that do this. But also, collaboration and rehearsal. And I think one of the things we did, although this, I don't know how this helps the managers, but just as an example, John, when we did data migrations, so where we would be taking data from old systems, bringing them up to speed with new ones, then of course you're adding new capability. The industry norm was to do about 3 or 4 rehearsals of that data take on. We used to do 14 or 20. I mean, we rehearsed it like we were going to be playing in the Royal Philharmonic Orchestra in front of Her Majesty the Queen. We just did it so that we could do it. And we literally I remember 2 instances. We amalgamated 8 million records and 7 didn't match. 7 didn't match. And we did it another time with 12 million, 100% of them matched. And we did it in something like 45 minutes, which again was a bit of an industry breaker. So I think invariably somebody has done something like it before. You might be doing something pioneering for the first time, but as with all things, stand on the shoulders of giants. Who's done it before?
I'm loving that expression, Shane, standing on the shoulders of giants. Michael, just before I come to Hassan, back to you.
Yeah, I was just going to add, actually, Shane's absolutely right. I mean, some of the healthcare managers listening to this cast mightn't be even aware of who's done it before. So a great example would be the testbed program, the NHS testbed program. That NHS testbed program was designed to drive innovation, and there was a huge amount of digital transformation and technology involved in that. Those stakeholders are listed. They've been collecting the journey that they went through, and part of that testbed program was to look at what are the processes that we're building. How are we measuring them? How are we making them effective? And how are we implementing them? And that's all documented. And all of those members are available to pick up the phone or drop an email to, and they will talk you through their experience. The great thing about those is that they're all so different. Some of them are hospital transformation piece, some of the community, some in mental health, and some in cardiac surgery. A whole range of NHS testbed programs have been run, and all of them would have some invaluable insight that would actually help guide how the healthcare managers start to develop their programs of work.
Thank you, Michael. Okay, Hassan, come on, last word on this one. How do you remove the fear from the eyes?
You've had some fantastic answers. There might not be much left for me to say. The first thing is that the best book on this topic is by someone called Ronald Heifetz. And he wrote this book for the Harvard Kennedy School. It's called Leadership Without Easy Answers. And in this, he says that what we have here is called an adaptive problem. So forgive me, a bit of jargon. An adaptive problem is where the solution isn't immediately obvious. It's not a mechanical thing. You can't just say, look, you've got a urinary tract infection, take the antibiotics, drink water. That's a mechanical one. There's one which a blend a bit of a mechanical and an adaptive, where you're telling a patient, look, you've got heart disease, stop smoking. So you can tell them what to do, but the patient has to still be concordant and persistent with the therapy. So there's an element which is a mixture of mechanical, technical, and adaptive. Health IT is the mother of all adaptive problems because there isn't a straightforward answer because you don't really know what's going to go wrong. So many things could go wrong that you have to have strong leadership so that you can adapt. And therefore, the fear is warranted because it requires someone with the strength of leadership to say it's okay for it to go wrong. We're going to plan for it. We're going to drill for it, which is actually where Shane's example comes in. It's about knowing that it's going to go wrong and saying, we're not going to be scared. We're going to prepare. We're going to get it right. And that's why I want to give the example of who I think one of the best CCIOs in the country, Dr. Torrell Thomas, Norfolk and Norwich. He deliberately went to pretty much the worst performing mental health trust he could find, so that he could prove his theory about how you make change. And there's the GDEs, the Global Digital Exemplars, have got blueprints. He says, no, blueprints don't help. They tell you what to do, but they don't tell you what's going to go wrong. So he's pioneered the idea of red prints, which are, here's what went wrong the last time we tried it. This is what you avoid. And if you get enough red prints, you know what to avoid, you know what to plan for, and you can adapt. And that's how you get rid of the fear. You know what could go wrong because it's been implemented 6 times by 6 other people. I know what went wrong. I know what to avoid. That's how to get rid of the fear.
Oh, that's a wonderful answer. I love the idea of red prints. I've not come across that personally. So That's a cherished memory I will take away from this particular session, Hassan. Thank you. All right, gentlemen, we've got about 10 minutes left. So what I'm going to ask you to gather your thoughts, because I want you to summarize, each of you, 3 pieces of advice that you would give to any manager or leader involved in digital health, social care technology, some kind of a potential design and rollout of something new. I'd like you to think about 3 pieces of advice that you would give them to insulate them against the sorts of mistakes that typically get made all too often. Because we want to help our IHM members to look brilliant and be brilliant, because they are brilliant. So 3 pieces of advice each of you. I've given you a big enough role in there to allow you to gather your thoughts. And I think I'm going to come to Hassan first here to give us those 3 pieces of advice that he would give to managers who are taking some kind of role or responsibility in a digital health technology rollout. Hassan, what would you say?
Thank you. So I'm going to give 2 pieces of acting advice, right? And then I'll make it relevant, hopefully. The first is to imagine the audience naked. And the second, I don't know if you've done this before, is to wriggle your toes. And in the wriggling of your toes, you're not worried about anything anymore, because you're now breathing differently, thinking about your body. It takes your mind off the problem. They're both about your perception of the problem in front of you. Don't let it overwhelm you. Don't let the fact that it's digital and blockchain and artificial intelligence scare the pants off of you, because it will if you're not careful. Think of it as a business problem, a human problem, something that you can solve because you've done these things before. So ignore the digital side of it. Focus it as a simple problem, you'll be fine. The second, everything, and I mean everything that you want to do, unless you're really unlucky, has been done somewhere else by someone else already. It's about how clever you are about your research, how deep you go, who you ask, how well you connect. And that's why it's amazing to have the IHM and the Academy of Fab stuff, because you know you can go and find the answers. There are communities upon communities out there that will help you. And the last one, which is a really, really big challenge for the leaders, you might have to look at what's gone wrong in other places and learn how to adapt. But if you can get into that, then you can solve anything.
Hassan, thank you. I knew you'd be a good, strong start point there. That was fantastic. Thank you very much indeed. Shane, I'm going to come to you next, I think.
Hassan does really set the challenge, doesn't he?
He does set the bar high, doesn't he?
All
He does set the bar, I know.
I've learned so much. Thank you, Hassan. And the red prints thing is amazing. 3 things: openness, your mission, and doing your homework. So for me, there is a fear with a lot of people, which is about saying, I don't know. And, you know, this is in all aspects of life. And I think Bill Clinton was famously quoted that since he stopped being president, he does 2 things every day. And one of them is says, I didn't know that. And I think it's important to start with, you know what you know today, do leave your ego at the door, but be open. And that's about building a team around you, and it's about working with people. And those people are above and below you and alongside you. It's about serving your mission, which is my point number 2. What is your why? Why is this thing being undertaken? Even if it's not at your inspiration, but you have to do it, it's your obligation. Work out what it is. And the big thing that, you know, both Michael, yourself, and Hassan today is speaking in a language that people understand. And that is finding the language. What's the mission we're trying to achieve? Why are we trying to do it? And that brings me to the third piece, which is, it is about doing your homework. There are no shortcuts to a lot of things, other than there are shortcuts to ideas. You can stand on the shoulder of giants, you can go and listen to people, you can steal their ideas willingly. And one of the things I've been privileged throughout my entire healthcare career is whenever I've asked anybody of a question, every time in 30 years, somebody has willingly helped. And that's part of this session, isn't it, John? And it's part of the IHM, and it's part of the Fab Academy. People willingly give their knowledge if you ask for it, and they love to help. But you do have to do your homework. It does require preparing and rehearsing. And the final piece I'd add to that third point, if I may, John, is envision the outcome. When it gets really tough, when you've put in some long days, when it's the night before you're going to go live with a thing, whatever it is, do envision the outcome that you're going to benefit from when all this work's been done. And don't forget to celebrate it with your colleagues.
I'm loving the celebration element, Shane. I'm glad somebody mentioned that. Thank you very much. Michael, come on. Last but certainly not least.
Well, I think for me, one of the first pieces of advice is don't be afraid of this, you know, because there's no such thing as a stupid question when it comes to this kind of thing, you know. Those people that are considering it are generally breaking new ground, you know. They're trailblazers. And I, you know, whereas we say, you know, go and speak to somebody who's done it before. Yeah, do that, definitely. But be mindful of the fact that you should be proud of the fact that you're trailblazing, you know, that you're creating something new, you know. And so there's a level of enthusiasm, you know, and respect that you get when you're doing this. And the other thing is, don't be afraid of the rest of the technology industry, you know. I mean, they'll bamboozle you with this phrase and that phrase, and yeah, keep it simple is the answer here, you know. These companies, you know, they want to sell you their services, they want to sell you your product, you know, and you'll have to differentiate in that respect. But don't be afraid of it. You'll learn a huge amount from them. So as people are going around the conference, you know, speak to as many people as you possibly can, you know, get their contact details, take their literature, you know, take it home, digest it, you know. And if you've got a question, you pick up the phone, they'll give you an answer to the question. They want to help you, you know, because they want to collaborate, you know, they want to work in partnership with NHS stakeholders. And they're in it for the long run, you know, not just for a quick win. So, you know, take full advantage of the conference that you're at while you're there today, you know, over the next few days. And then the last piece of advice is, when you're considering what you're doing, make sure you've got the right team around you, you know. Spend time thinking about who you want in your core team, you know, because if you've got a really good, strong core team that respect each other, willing to work with each other and can get the job done, you'll deliver a really great result.
Thank you, Michael. I must say, gentlemen, I think you've all distinguished yourselves with some really good answers, certainly to the three pieces of advice that you would each give. I well remember going back into the summer I had the idea that we would do a conference, a virtual conference via Zoom for no going back as the theme, you know, amplifying all of the good things that we'd all done as a result of COVID. And I had it in my idea that we would have 6 different streams in breakout rooms with 300 people on the event. And none of us had ever done anything like this ever before. And at the end of it, yes, there were some catastrophic issues along the way during the whole thing. But you know what? The audience didn't notice. And if they did notice, they thought it was quite funny. We got it back on track and everybody had a good day. So the important thing is these things eventually they work through and you will be regarded as the pioneer. And the pioneers are the people that we salute because they're prepared to take arrows in the front as well as in the back. And you should be really proud of the fact that you are the trailblazer, as Michael has said, you are the pioneer, and you're going to make this work on behalf not just of your organization, but for the well-being and welfare of all of the citizens of the United Kingdom who use our services in health and social care to make them feel well and make them healthy. So that's my final word on the subject. Be proud of what you all do because you're all doing the most fantastic job. We've reached the end of our time. I've got to say a huge thank you to my fabulous panel. You know, they are trailblazers themselves. They've all done a marvelous job. So thank you to Michael Morgan Curran. Thank you to Shane Tickell. Thank you to Hassan Chowdhury. Brilliant all. That's it from me, John Wilkes, Chief Executive of the IHM. Do enjoy your experience at the Giant Health event. And thank you for tuning in to the IHM's session. We've much enjoyed having you. Bye-bye.
Welcome, everybody. Welcome to our Digital Therapeutics track, where we're going to be talking about, is it overpriced or underpriced? And we have amazing speakers today. And it's my pleasure to introduce our first speaker of the day, connecting with us from Germany. I would like to introduce Luisa Wasilewski. She's an expert in digital health, a published author, and today she's working on the digitalization of a German clinic chain. Lisa, welcome.
Thank you so much for this nice introduction. And yeah, thank you for having me. I'm very happy to be here today. and to be talking about digital therapeutics with you guys. So let's get started. I constantly wonder, actually, in my day-to-day job, how will digital health solutions shape the future of our day-to-day lives in 5 to 10 years? So what will truly be embedded in our understanding of healthcare, medical services, and what won't? And I believe that one version of looking at it could be that the solutions will win that A, address a widespread disease such as chronic diseases, B, do that in an evidence-based and also medical recognized or certified way, and C, do that with a very good user experience. With all the technology trends hitting healthcare right now, I believe that one trend will be for sure be there in 5 to 10 years, and that is digital therapeutics. So let's talk about definitions. So what is actually a DTX, a digital therapeutic? DTX deliver evidence-based therapeutic interventions to patients. And they do that by usually a high-quality software, some kind of app. And the aim is to prevent, manage, or treat a broad spectrum of physical, mental, and behavioral conditions. So we're talking treatments here, we're talking therapy. And the catch with DTX is that usually they need a proof that they actually change the behavior of the patient, which is also a characteristic of a therapy, right? And that means that some solutions don't count as a DTX. And those are purely played adherence tools, diagnostics, or telehealth. And that also means that most of DTX out there in the world usually can show through clinical trials that they actually have somehow an effect on the patient and they actually change their behavior. We see a few fields in DTX that are, let's see, very popular in demand, and that are chronic diseases, mental health, and also rehab and addiction. And it makes a lot of sense, actually, to address such conditions in a digital way, because patients with chronic disease usually need a constant treatment, monitoring, or interaction. So a therapist can't be there for every panic attack its patient has. He can't or she can't call every day to ask how the patient is doing. But an algorithm or a chatbot logic actually can. And that's why we see also a lot of solutions in this market. And when you think about it, chronic disease, at least in Germany, almost every other person in their grown-up lives actually deals with chronic disease in Germany. And over 18 million people have mental health issues here. So we're also talking big markets here. And since I also want to do some name dropping about German startups, I want to tell you who are the big players in Germany. So there's MySugar. I think that's a pretty well-known one. Diabetes treatment. There is Kaya Health. That's a rehab app that actually aims to replace the physiotherapist, which is quite great because they not only provide you with videos what to do on your yoga mat at home, they also film you by doing it, and then the video algorithm actually goes over it and tells you what you did wrong or what you did good. So actually exactly the service that a therapist would do in a face-to-face consultation. And then there's also another startup in mental health that's called Hello Better. And they provide courses, and they kind of like connect the dots with an actual person, like a therapist, and also an ongoing digital treatment at home. So most DTX today actually have the goal to support and add to the doctor services. But when you ask me, I actually believe that the future will hold something more differently. We will actually see more and more solutions that will aim to replace the doctor to a certain extent, or maybe even fully. And there are reasons why this actually makes sense. Sometimes no doctors are available or too expensive. Even in Germany, that is the case for lots of mental health conditions. But also when you think about rural areas or developing countries. And B, when you think about it, there will be a time where algorithms make less mistakes than humans. And why shouldn't we make use of this innovation? Why shouldn't our therapies actually benefit from it? So looking at the market today, why is now a good climate for DTX to actually reach new heights? Right? DTX is nothing new. MySugar it's been on the market for a decade. But now is a preferably good time for such solutions because the environment where the technology operates and the infrastructure and the acceptance by the user is getting more and more into the masses. In my book, I actually talk about technology trends that are hitting the market, and it's the German market. So yes, we're a bit slow on the infrastructure side, which is the first technology trend that I'm talking about. So the electronic patient file, the e-prescription. The second trend is that we see that the access to doctors or to medical service providers is being digitized, such as video consultations, right? In the pandemic, video consultations had surged in usage all over the globe. And the third trend is the quantified self trend, where we see that collecting data through sensors or to apps is moving more and more from a lifestyle sector into a medical sector. And those three trends, at least in my world of trends, are more of baseline trends. Those are trends that will enable other technology trends to actually come alive. And that's what we see with digital therapeutics today. Because if we don't have an electronic patient file that works hand in hand with the DTX and actually connects also the service provider to the digital tool that you have on your phone, it's going to be hard for them to actually reach the masses. The same counts with acceptance of using digital tools, right? With the video consultation, people are getting more and more used to actually using a digital tool when interacting with a service provider. And then also with no data, the algorithms, they're kind of bad, shit in, shit out. So we need to collect data to actually make the intelligence work better and better. And since we see these three baseline trends emerging into the masses so rapidly right now, I think now is also a good time for DTX to actually fly off and reach new levels. But to also make that happen, what are the big hurdles? What are the barriers that they still need to overcome today? So healthcare is a complicated market, right? So there are a lot of hurdles. But let's look at three big ones. The first one is that the government and also the payers need to address the bureaucratic hurdles that exist to get DTX reimbursed. Healthcare is in most EU countries not a self-payer market. And therefore, it can be hard for startups or for providers to negotiate their way into the reimbursement contract. The German government has actually done something pretty amazing here. I don't know if you've heard it, but we actually have a bill passed that make apps being prescribed by the doctor when they have a certain certification, which we call the DiGA. And what that means is the state actually certifies DTX products. And once you have that certification, the doctor can prescribe it via prescription, and then the payer has to pay for it. And there's no negotiation, they just have to do it. And also what that means is that patients can go to the doctor and demand for a DTX, or doctors can give the patients the DTX that they strongly believe in, which makes this hurdle a little bit less scary for the startups. The second hurdle that I would see the market has to overcome is that the startups that want to do innovative stuff in this area, they need to understand the tricky and highly regulated healthcare market. So they need to tick off all the regulatory must-haves, such as clinical trials, such as certifications. In Germany, the DiGA one, EU level, the medical product one. And even today, I see from an investor's perspective, because I also invest into startups, in my current job, I see that most startups still don't really take it serious. They don't take it serious enough, but you need to understand it. You need to have the right investor at hand that gives you the money to go through a clinical trial to tick off those must-haves. So you have the certification, you are in a market where you can get reimbursed. So that's pretty good, right? But it's only half of the job actually, because then the new game starts by reaching your end users. And when it comes to DTX, that's not just the client, the end user, the customer, the patient. It's actually the doctors too. So startups now need to find a way to convince doctors or medical service providers that they are a good product, that they actually have the evidence, that they actually have the clinical trials. And they also need to educate the end user on how to use a digital therapy. So if governments, payers, medical service providers, and startups work towards the same goals, I believe that all of us will be using some kind of DTX in the next 5 to 10 years. So that's my perspective on it. What do you think? Are DTX the next big thing in healthcare? What hurdles and barriers do you see? I'm very excited to see the discussions of the following panels and wish you all a great experience with lots of insights.
Thank you, Lisa. What a great way to start the track. So interesting, everything you had to say. And thank you so much for laying the land for all of us to catch on with the conversation today. For our first panel, it's my pleasure to introduce to you Aline Noisette. She's coming from Spain, and she's a health connector, passionate about creating space for all stakeholders of the digital health ecosystem to come together. Welcome, Aline.
So in this panel now, we're going to discuss how those digital therapeutics are putting the person at the front and center of their own care, and the importance of clinical validation. So those past years, digital health has been accompanied by a multitude of solutions that could fit in the patient's pocket, thanks to the smartphone. And it's been a challenge for both patients and healthcare professionals to know which solution to choose, and especially which one is safe to use. But things change with digital therapeutics. And in this panel, we will discuss with experts what it takes to validate those solutions and how they're empowering people. So it's my pleasure to welcome our panelists today. So first we have Dr. Chandana Fitzgerald. She's a medical doctor with work, research, and educational experience across European, American, and Asian markets. And she's currently driving global collaboration in digital health and medicine at Health Excel. Then we have Abhishek Shah, is the co-founder and CEO of Wealthy Therapeutics, a digital therapeutics company that uses a human AI hybrids along with clinically proven behavior change models to drive patient health outcomes. And finally, we have Will Gibbs, principal at Octopus Ventures, where he leads the Future of Health team, and he sits on the board of a range of health companies, including several digital therapeutics companies. So welcome, everybody. It's a pleasure to have you here this afternoon. So I would like to start the conversation with Chandana. So Health Excel, together with Digital Therapeutics Alliance, Node Health, and Digital Medicine Society, you help define the definition of digital therapeutics, comparing it with digital health and digital medicine. Can you tell us a bit more about that?
Yeah, absolutely, Aline. So this, when you mentioned this, it took me back to last year when we started these conversations, and so much has happened in just the 1 year that the framework, while still very relevant, seems a bit old and dated. I think it was launched in October or November of last year. So basically the 4 organizations that you mentioned, and we basically came together over a period of months to really try and identify and define clearly what is the difference between digital health and digital therapeutics. And the reason that this was really important and still continues to be topical is because digital therapeutics are software interventions that are supposed to help you treat a condition or manage a condition. So it's a pretty heavy label claim to make. And in order to satisfy that, we need to make sure that there's the right rigor of evidence generation, the right regulatory pathways that such a product goes through, etc., before it's actually used by an end user. And we wanted to make sure that everybody in the industry actually understands these nuances and these differences between something that you can just go online and purchase as a watch or a ring or whatever, versus something that your doctor is going to prescribe with the objective or intent for that to cure you or treat you, be an integral part of your management. So it was really to help ground everybody in the industry and differentiate between the different products in the market, to say every product has its place. This is not about right and wrong. It's about what are the requirements and needs depending on where your product belongs and which category you're really going after. So interestingly enough, we launched that. I have to say this though, it was literally a group of us, 5 women who would meet every week to put this together. I just had to throw that in there. And it was a really fun experience. And since then, actually, I just realized recently that Wikipedia has its own digital therapeutics page, which is super interesting. And I know, obviously, I think this has been quoted there. And then Lancet, Nature, all of them have actually come out with their own kind of pieces on what digital therapeutics are, why we should pay attention and help differentiate. So I think since we launched this, it seems like it's a bit more well understood, and it's becoming a concept that people are trying to understand better. But really, when we started out, it was to help define it and set the tone.
Fantastic. Thank you so much, Sanchandana. So something that, I mean, you touch on it a bit now. And so we feel that digital therapeutics are really like empowering the patient even more, right? That's what we want to discuss today. They're putting them front and center of their health. But how are they really helping them? Like, what's the added value? Abby, do you want to start? What's your view on that?
Sure. The best part about a digital therapeutic is the patient is much more in control and gets a much larger voice on whether it's working and whether it's adding value for them or not. It's not just a perception of the health system or some study, right? We've seen some incredible segue as an industry where from everything starting from improving a clinical outcome to improving symptom management to improving quality of life to empowering somebody with the tools to be able to make better decisions either through a day, through a week, through a month. At the core, it's about a very special word, right? It's about empowerment. And we've seen whether it is digital therapeutics in respiratory conditions like asthma or COPD, where you're helping drive down the risk of ER visits or hospitalization visits, or improving symptom-free days, or in heart failure, reducing risk of rehospitalization so that you can live your life a little better, or you're looking at type 2 diabetes, where improvement in quality of life, improvement in HbA1c, better glycemic control, reduced hypoglycemia risk. Frankly, the list is endless. If you look at Olina and Volantis and what they're doing in oncology to improve the patient's quality of life and symptom management and even triaging to an extent, there's such incredible work that's happening out, but it's all with the patient at the center to empower the patient. And that's truly special because it influences real world outcomes at scale. So there's a lot going on.
Will, so you invested as Octopus Ventures in different digital therapeutics companies. So what's your view on that? How is it really empowering patients?
Yeah, so I suppose for me, the two most obvious examples are probably the ones that I'm closest to. So I sit on the board of a business called Quit Genius, which uses digital therapeutics to help with substance addictions. And that business, so the gold standard for quit rates for those looking to quit smoking is around 24 to 25% of the UK. Quit Genius have demonstrated at scale that they can deliver a 50% quit rate. And so I think a similar trajectory is true of Big Health, which is another Octopus portfolio company going after insomnia and anxiety. And for me, I see it as quite interesting in that I think the first wave of digital therapeutics was showing efficacy or non-inferiority versus other pharmaceutical routes. I think that has now clearly been proven. And I'm quite excited for what the next wave of this is, which I think my gut is that it's more around the cost to serve digital therapeutics and how you can make this more of a population health approach rather than being reserved for employee benefits where you're talking hundreds of dollars per head, which I think has value in some contexts, but still has limited reach.
Yeah, I'd agree. I feel like we should probably be asking some patients if they feel more empowered using this, right? That would be the best way to judge. But I'd agree with everything that Will and Abhishek have said in terms of, it's the cost saving for a patient. It's their involvement in their own treatment, potentially understanding a bit more than what they would if they just took a drug, because there is that data feedback loop as well. So a bit more of involvement in your own care. And I think perhaps just a better understanding of what goes into it, because we, in our day-to-day lives as well, use apps and other things, right? So something that they can relate to better than, say, a molecule that's going through all the motions before they consume it. So I think there's a few different ways to look at it.
Fantastic. Thank you. Abby, let me go back to you. So you have developed a digital therapeutics yourself, Wealthy. So how do you clinically validate software on an app like Wealthy, and what are the challenges compared to traditional therapies when it comes to validation?
So we have the good fortune of not having to worry about the challenges of traditional therapy, because that's not, I guess, a skill set we never ever had. Pharma does have that problem. But for us, it's essentially the same first principle, which is what is the claim that that the digital therapeutic is intending to make? And then how do you work backwards from that claim to be able to ensure that from the study design to the protocols, to the way in which it's delivered, to the control or placebo, and now the placebo is more and more becoming another app, which just doesn't have the actual therapy inside. But how can you truly demonstrate with the same gold standards that RCTs have maintained all this time when it's been molecules that have been going through that journey, that you're able to generate the clinical evidence to showcase a clinically significant delta for the same claim for which you are designing the therapy to begin with. Because at the core, it boils down to that. You cannot possibly put a digital therapy out and then we'll figure. That's just not how it works, right? Versus you almost go back. The advantage that you have versus a molecule is that you can almost reverse engineer basis the claim and then goal seek back what do you need to build the digital therapy to be to ensure that you deliver on that claim. And then comes the harder part of being able to demonstrate safety, efficacy, reproducibility, scalability of that claim. Because the minute you traverse geographies, you traverse health systems, you traverse different patient populations, digital therapeutics has the one, privilege and curse of real world first. Which is vastly different, and user experience is dramatically. If you're popping a pill, it's popping a pill. Versus so when you're engaging with the digital therapy, there's a lot out there that you have to encompass. But it is essentially mapping the different claims, working backwards from building a digital therapy that enables that, and then proving it again and again over the time period that's necessary with the designs and checks and balances that are necessary. And then after that, building enough evidence to be able to go to the regulator to be able to file for it, and at the same time start making the case for the payer. Because at the core of it, it is something that still needs to be reimbursed. So clinical validation, thankfully, is deep-rooted within the healthcare system. It predated digital therapeutics. It's just about using the same first principles to get there, I guess.
Awesome. So, Will, I have a question for you, because look, we just heard Abby talking about clinical validation, but that's needed when you have a DTX, right? But I hear many startups who are developing DTX solutions struggling because they need investment to the clinical validation. And then when they go to investors, the investors want to see the results of those validation to put money in them. So what's the solution there? What's your point of view as an investor?
Yes, I suppose firstly, I would echo the point just made around, I think the expectation of clinical validation is a reasonable one when you are competing with pharma who have put tens of millions at least in R&D and put drugs through kind of 3-phase trials. So I think there's an assumption. I think that is a fair one. I think one of the first issues or challenges is that I think a lot of investors lump DTX with consumer or gaming businesses, where maybe a typical seed round might be £2 or £3 million, and just trying to prove what you need to prove as a medical business on that type of runway, I think is challenging. Whereas if you see DTX or digital therapeutics businesses more akin to life sciences, where actually these businesses are IP rich, will require a lot of investment and sophistication to go into them, where maybe a seed round into those types of companies is probably 3 or 4 times the level you'd expect for a typical consumer business. I think it just speaks to the need of acknowledging this requirement from an early stage. And DTX founders, if they are planning on playing to win, should make sure that they're raising enough money and shouldn't be surprised when this comes up further down the line. But I would say that it is a sliding scale. And so Big Health, I think, has now done about 10 RCTs. Quit Genius, I think, has published about 2. And so for me, like, that is clearly like the A+ level of clinical validation, where you've got RCTs peer reviewed with an external data set. So it's not your training set of data. That is as good as it gets. But equally, I think if you've got early pilot data with a small group, it's non-peer reviewed, there's a bit of extrapolation that's needed, but some of the core hypotheses kind of make sense. Then I'd probably say that is a kind of middle ground. And then at the other end of the spectrum, if you've got a clinically minded team with a solid advisory board, deep expertise in this area, you then end up in a territory where you're using some of these data points as a proxy for clinical validation. And so I see it less as a binary, like, do you have clinical validation or don't you? But more, what is the quality of that clinical validation? What is the existing clinical risk? And that clearly also links to however much money you're looking to raise.
I completely agree with that. I also want to add to that, Will. So exactly like you said, it's the quality of the evidence, right? So what's the size of the trial population? And one thing I've noticed with a lot of digital health products broadly is the methodology, right? So you can define the rules to make your results look really good as well. You're basically studying on a patient population that will definitely use this particular treatment for 20 minutes every day or whatever that is. And so then your results are a bit skewed. So I think taking the time and putting in that rigor into the trials for this is absolutely essential. And if we can wait years, decades, sometimes for molecules, I think giving digital therapeutics the months or the couple of years, I think, is definitely worth our time.
And I think it's also, I think the investment piece is one part of it, but in terms of also what having clinical validation actually enables as well is really interesting. And so Big Health signed a big partnership with CVS in the US, which is a game-changing deal. Without their RCTs, these types of channel partners just wouldn't get involved. And equally, Quit Genius signed a big deal with Express Scripts, which I think is one of the top 2 or 3 pharmacy benefit managers in the US. They make about 100 billion a year. And the level of rigor that channel partners want to see before they will put your product on their menu of services is a really high bar. And I think the challenge is typically when you want to have those conversations and they say, okay, we need to see your clinical validation, it takes years to have this. And so unless you started this process a long while back, and I think it's more useful to see it as dialing this up and dialing it down, depending on what your available cash is, versus saying, okay, next year we're going to do clinical validation. I think it's probably more a percentage of focus rather than an on or off.
Abby, do you agree with that? I see you nodding.
Yeah, I agree. I do. I would just add that there are other models that allow you to go to market quicker without necessarily having to go down the route of a digital therapeutic clinical trial first. We were fortunate enough to take a start which was slightly different. When you're operating in, say, emerging markets, or if you have the opportunity to go direct to consumer, in some cases, you have the capability to go out there and start building on your product. And clinical trials don't have to be the step one in that journey. It just needs to be a step before you go down a regulatory pathway or you go down making a claim. But that doesn't mean you can't. There's a large universe out there, where B2C is perfectly reasonable. So just calling it out that, whether it is, the equivalence of the Livongos of the world, or a lot of companies that are in employee benefits, I've seen incredible innovation come out where they haven't gone down the regulatory pathway, they haven't gone down the clinical trial approach, and they've still been able to build reasonable sized businesses and scale those businesses. So that may not be the only way, and I've seen digital therapeutic companies, therefore do that as maybe step 2 in that journey to appease the investor gods, while at the same time building enough traction, enough data to ensure that they can raise the capital that is required for the rigor that is absolutely necessary for this pathway.
Totally. It's all about what the claim is.
Shandan, would like to carry on with you. So talking about an important player, an important actor in this DTX ecosystem, the physician, right? The healthcare professionals. So Mobi Health News, they published an article recently, and they said that the physician will decide the fate of the digital therapeutics industry. As a physician yourself, what's your position on that? What do you think?
I think it's a point really well made, because ultimately, we are saying a digital therapeutic is a product that has to be prescribed by a physician to their patient. So in order for that to happen, the physician is a really important person in the equation here. And if we just reflect on how drugs make it into treatment protocols, right? This is the first line therapy for X. This is the second line. It's through working groups of physicians. And historically, that's how it's come into guidelines. And in order for digital therapeutics to become like a default therapy for a particular indication, it has to go through these similar pathways. I'll say it has to be approved by working groups of physicians. It has to be in the treatment guidelines for a particular condition and so on. So the physician has a really important role to play here. So it's about awareness to begin with. So if I reflect on a lot of my friends who are still obviously very much active in clinical practice, honestly, they've never heard of such a thing, right? For the most part, it's maybe some of them have just read about some of these technologies in passing, but it's really not an integral part of their day-to-day care. And so there's a huge awareness piece. We do so much as an industry to make sure that HCPs understand what are the new drugs in the market, what are the side effect profiles of these products. And there's so much information dissemination happening, and we need something similar for digital therapeutics as well. And go way back, nobody learned about this in med school, and then it was not part of your residency, it was not part of your practice, and nobody's even telling you. There's no MSLs knocking on your door and saying, hey, learn about this product, report your adverse events, none of this. So it's not at all integrated into the existing workflow, if you will. So if we get all those pieces right, I think it's absolutely critical for these products to, scale.
Abby, in your case, how do you do to reach the healthcare professionals or to educate them on the existence of Wealthy and why they should use them with their patients?
So we did reach out to HCPs through building our own team. But very quickly, I think we found a better win in actually combining forces for the same claim. A lot of our partnerships today are with pharma, where we're working very closely with pharma to be able to build, for lack of a better word, combination claims, because it's a win-win on the real-world outcomes. And therefore, we get that opportunity to work with pharma's teams to be able to build therapy advocacy. But it's an even longer pathway, as you can imagine, to be able to get that partnership on board and to be able to get that alignment, because pharma is still figuring out what is its digital therapeutic strategy. At least COVID has ensured every pharma company across the world now has a digital health strategy, which has gone beyond digital marketing. But we are still a while away to be able to get to digital therapeutic, and therefore a joint claims or an individual claim strategy on using a digital product. But for us, outside of building access through payers, as Will pointed out, pharma is a great partner as long as you can find that alignment towards the claim that both you and the pharma partner are looking to make.
Awesome. And so, Will, there's like DTX companies like watching us now, they are looking for investment. Like maybe if you can share some tips with them, like you as an investor, what are the criteria you're looking at when you're investing in a DTX company? Maybe is it the therapeutic area, geography, clinical validation, as mentioned before?
Yeah, sure. So just as a selfless pitch, all of my contact details are online, and I'm always keen to hear from businesses. We kind of invest anything from £1 to £10 million. typically as a lead investor. But I would say that I think my experience with a number of portfolio companies over the last 12 months has probably put a few of these points into closer focus around what is mission critical for a team that could genuinely win in this space. As expected, the first point clearly has to be team. But just to qualify that, I think I'm increasingly of the view that building like a digital therapeutics business at scale is very hard. And even things like seasonality of buying cycles, if you're selling into the US market, is really complex. I think the business models are also very complex, where you're not charging on a recurring basis, you're charging on a per employee or per user per month basis. I think the incentives of even how you bring a product to market as well are really complex. And I think it's only through investing in companies in this space that I've realized how complex and hard it is to actually scale these businesses. And so I think having a team that can hire genuinely best-in-class people and don't hit that talent ceiling, I think is probably top of my list. I think the second point is probably around ROI and health economics. That I find it quite saddening that there's lots of businesses that might have the best technology in the market, but if you can't package it up in the right way, and if you can't demonstrate clear ROI to the right person, the technical superiority is irrelevant. And so if I take Quit Genius as an example, so the average smoker in a US company's workforce costs about $3,500 in additional healthcare claims for employers. And so Quit Genius has strong and well-validated claims that they can get employees to quit smoking with a 50% quit rate, and they put their fees at risk. So they say, we charge $800 per employee, and we will get half of your smokers to quit. And those type of economics, when you put them down on paper, makes so much of a difference to potential buyers and potential partners. And I think that's often an area that I see undercooked when businesses are pitching digital therapeutics, is that kind of so what test. And I think especially like Heather and the folks at Optum, I think especially clued up on this topic, where budgets are increasingly tight, which means that there's even more stress that buyers and partners are placing on the financial efficacy and impact. So I think the behavioral, the health economics bit, I think is often overlooked, but really can't be. And I think the last attribute that I think is important is around agility. I think this is still a very dynamic market, and seeing kind of the Teladoc Livongo transaction, like actually asking yourself the question of what does this mean for CVS? What does this mean for all of the other telehealth players? What does this mean for consolidation in the space? Equally, the announcement of the German like insurer reimbursement model of like, okay, what does that mean for our strategy across Europe? How do we think about pharma as well in this? That there's so many stakeholders that I think it's also really important that you have a team that still has focus, but equally is able to see that some of these doors open and close fairly quickly. And I think unless you're agile, there's a risk that there can be whole market opportunities that could easily pass you by. So I'd say team, ROI/health economics, and agility.
That was great. Will, thank you so much. I hope investors, like startups, you took note of all those very valuable insights. So now I would like to address some questions that were asked in the chat. So the first one is, how do you monitor the progresses from a patient perspective and make sure that the solution is redesigned throughout time? Maybe Abby, you want to take this one?
What is the number one thing that startup has that a larger company doesn't? And I've always asked myself this question, right? Doesn't matter whether you are, in any industry. The only currency that you have that a larger company does not have is speed. And if you cannot use that to your advantage, you're going to be dead in the water, because anyone that tells you they know what a patient wants to be able to achieve the claim that they want to make I will win that bet against them every time. Nobody knows. What you do know is iterations will get you to product market fit. It is, and those iterations can be 2 years long. Those iterations can be 2 weeks long. And the difference between a good and great company is going to be those that are able to rapidly iterate. So it's not just about putting something on the ground, but listening, learning, taking insights, bringing that back into the tweak on the hypothesis or the experiment or the A/B test that you're running, and doing it again and again and again and again. And this is between with your clinical team, your product team, your design team, your engineering team, your go-to-market team. And I can't tell you how, if somebody told me this 5 years ago, I would have hugged them, because it would have saved us a lot of time and effort. But today, by the way, is our 5-year anniversary. But that's what I would say, right? That if you are able to bring that to the table, that's when you will truly understand the designs that are needed for patients. That's when you will truly understand what patients want, what HCPs want, what really is adding value. And unless you have that agility loop, as Will pointed out, and translate that into what I would call iteration loops, using speed as a massive strength of yours, you either would be late to the party or you will miss it altogether.
Perfect. So I have another question. So it's a question with 2 parts. The first part is for Abby. The second part is for Will. So first part of the question, pharma is an ideal partner, but what are the key challenges in finding the right partner, the right pharma partner for your DTX?
So I'm happy to go first. So I would say that, Big Health is called Big Health because they see themselves as the direct opposite of Big Pharma. So I think for some DTX businesses, they're probably so diametrically opposed to pharma that I could just never imagine them being partners. I think with Abby's commentary, I think for me is eye-opening around how you can really kind of take advantage of the distribution. In that, I think really the biggest challenge for DTX businesses is distribution and go-to-market. And I expect that with the right pharma partner, they could shave kind of years or kind of multiple years off that. I think the biggest challenge for me is, I suppose, overlaying from an investor perspective, how you demonstrate that revenue trajectory in order to continue to be on that kind of venture-backed kind of growth expectation. And I think it's the same reason why a lot of DTX businesses struggle to make those graphs work, selling into the NHS in the UK, and then end up moving and selling to self-insured employers in the US, because you can maintain that trajectory. So I think one concern for me would be, whilst pharma could be an absolute game changer, there is a risk that you could also spend a long time kind of investing in those relationships. So I expect a lot of companies probably have a dual track approach of pharma and also more traditional payers.
Yep. To add, I think pharma is a great partner, but it's easily the longest gestation sort of cycle that you will have, and it's diametrically opposite to speed. Pharma will move things behind or up or down a year, and a year is death or win as far as a startup is concerned. So I'm a big fan of a dual strategy, but for pharma, you have to show the evidence. Pharma is not going to work with you on trust. Pharma is going to be putting their brand equity, their KOL relationships, everything that they've built on the line to work with you. So they are getting the same offer in different therapeutic areas, and that same decision maker is inundated with different requests. And at the core, you have to understand that trust is a big thing as far as pharma is concerned, because they're taking a massive risk. So they are an incredible partner to get on board, but don't expect them to come on board first. They'll probably come on board last.
Shandana, would you like to add something?
No, I think the two people who are best positioned to answering this have. One other thing I've heard is that obviously when you want to partner with pharma, it's challenging because they have they have the definitions and you have to fit into those. So it's like, these are our requirements. So do you fit in here or not? Because that's kind of how they operate, which goes a little bit against the constant iterations and the other piece that we've spoken about, which is the nature of these companies. So it's not a marriage made in heaven, but it's clearly a marriage that can result in scalability, big ROI potentially, and for both parties involved, while reducing it for the patient. So I think if it's a hard one to crack, but if we do, I think there's a lot of good outcomes from it.
Fantastic. So now, as a conclusion, I would like to ask each one of you to share like one best practice, one advice, something useful you found those past years and you would like to share with the audience today. Shandana, do you want to start?
Yeah, that's a really hard one. So I guess what I'll say is a couple of things, right? If you reflect on what works or what sticks, if you reflect on the Livongo model, etc., I'll say gift wrap your solution really well, because sometimes you don't have to do everything. It's the protocol exists, the guidelines exist, you just gift wrap it nicely. And the second thing I'll say is even if you don't necessarily need to build for to be regulated, but you can be sure that people wish that you are. So it's built for compliance, not avoidance.
Perfect. Will, do you want to go next? Your conclusion?
I'd say it's a very exciting time to build a DTX business. Like 5 years ago, people were just inherently skeptical that DTX businesses could deliver any value. I think those skeptics have been proven wrong. So I think now is a really phenomenal time to be building these businesses. And I think the clinical value on a global basis is potentially phenomenal. I think my one piece of advice is that don't feel just because you've got the best technology in the market that it means you're the best business in the market. If you look at Livongo, and I think where it's a public business, it's amazing looking through the analyst slides that so much of that success is down to go to market, understanding the channels, understanding the right incentives, and how you scale the business in a very smart way. And so I think just putting as much emphasis and thinking on how you make sure your product gets into the hands of everyone versus just making the best product. I think that would be my one key ask.
Perfect. Abby, last word?
Do one thing, do it really well. Don't even try to do two things. Do one incredible thing. Healthcare has this amazingly large landscape where every single one thing has a pretty large market. So if you have the opportunity, do one thing, because trust me, every single partner, every stakeholder, every advisor, every investor, every employee will tell you to do more than one thing. So if you can figure out that one thing and then stick to it, and don't stop until everyone tells you have arrived on that one thing, chances are that you'll be successful, and then you can go on to do two and many things after.
Thank you so much. Well, Abby, Will, Shandana, thank you so much for your time this afternoon, for your great insight, for your great tips. And yeah, looking forward to what's coming next with DTX. A lot is coming for sure. We have a great program this afternoon created by Anna. So everybody have a very nice afternoon and enjoy the rest of the program. Thank you.
Thank you so much. That was an amazing panel. So many interesting points that you guys touched on. I wish we had more time, but we need to move on our really incredible agenda. It's my pleasure to introduce you next, Edouard Gasser, connecting to us from France. He's going to talk to us about his TLAC Health and their product AutoSite.
Hi, everyone. Thank you so much for having me. I'm Edouard. I'm the co-founder, CEO of TLAC Healthcare. And today I would like to talk to you about AutoSite, our first clinically validated medical game, a game that monitors vision remotely. And especially today, I'd like to speak about how we managed to build and scale internationally the first mobile game to monitor vision remotely. Just to give you a bit of context on me, so I don't come from the healthcare industry originally. I actually come from the video game industry. And for more than 10 years, I've been producing mobile video games in a company that is called Gameloft. which is one of the leading mobile game publisher in France and in the world. And I've always thought that video games in general could be a great tool to help monitor and engage patients, and not only for entertainment, but also for greater good. And actually at TILAC, we create highly engaging, clinically validated medical mobile game to help monitor patients affected by chronic diseases. Just to give you a bit of context, there are approximately 2.6 billion people that are playing video games around the world right now. And if you think about digital therapeutics, one thing that is often underassessed is the power of retention and engagement in those digital therapeutics. If you want to have an impact on the healthcare process of the patients, you need to make sure that people are retained and engaged for a long period of time. And so at TILAC, we're leveraging on the power of mobile gaming to help retain patients for a long period of time. And at first, we looked at ophthalmology for one main reason. One of the co-founders is Professor José Lassalle, who is the head of the ophthalmology department at the Vision Institute in France, in Paris, but also the head of the ophthalmology department at University of Pittsburgh in the US. And also, when we looked at vision in general, we realized that the way we are doing vision monitoring right now is very inefficient. If you want to know what's happening with the patients, with the vision of a patient, you have to bring him in your office and you have to make him do a visual acuity test. And unfortunately, because of the lack of resources, you can't really find that many, you don't really have an option to bring that many patients too often in the doctor's office. And more specifically, when we looked at ophthalmology, we really were looking at eye diseases of aging, like AMD or diabetic retinopathy. Those are diseases that need a regular follow-up of their vision. You know, the patients that are affected by those diseases need a regular follow-up of their vision. Those are also the leading cause of blindness in the world. And unfortunately, if you don't have those regular checkups, you could end up being blind. So they affect approximately 217 million people. And because there is a lack of resources, as I was saying, it's extremely hard to know exactly when you can treat the patient in order to sustain the vision for a long period of time. And so we created Odyssey, which is the first medical mobile game to monitor vision remotely. It is clinically validated, and it's also a medical device, a class 1 medical device that is currently available in France. The way it works is that the doctor will prescribe the game. The patients will download it on their tablets, and then the data that is coming back out of the game is basically directly sent back to the doctor. I have a little video to show you basically. So this is the main menu, the saga map that we call it. So the way it works is that first, in order to have energy to play the game, you need to do your medical test. And here we have a unique technology that measures the distance of your face to the screen to make sure that each test is really consistent in terms of data. And then you have the game that you see here, which is a puzzle to reconstruct images. And that trains your visual memory in order to, obviously to make you test your eye on a regular basis. And when the product was ready and when we got our first our CE mark back in September, approximately in June 2018, we wanted to know very fast how the public would react, both doctors and patients. And so what we did is that we did a beta testing in France from September 2018 to May 2019 approximately, with 10 to 15 ophthalmologists and 200 patients, in order to see if there was a real appeal from the market for the product. And the results were really amazing. I mean, clearly we had really strong real world data. Odyssey was saving sites. What was interesting is that the average age in our application is approximately 70-year-old. And the first thing we wanted to know is there retention and engagement from such a complicated target audience. And we realized that we had retention and engagement rate that were comparable to Instagram. So our first, our first success was we knew that Odyssey would be played by the target audience, and that was super important. Second, we wanted to make sure that doctors were obviously very comfortable with the data they would get. And we had really good feedbacks from our users, from doctors that were saying, well, thanks to Odyssey, I have this safety net that allows me to know when my patients have a problem with their vision, and ultimately I can optimize their injection cycle in order to sustain their vision. And it became even more important, obviously, with the COVID crisis, when you had even less access to patients. So when we were at that point, knowing that we had a really good product that was working for both patients and doctors, we were like, okay, now how can we fasten the deployment, at least nationally, to have more doctors and more patients engaged? And since we are using a prescribed model, we realized that the best way to do that was to partner with, with a great partner in order to distribute the product. And so we secured a co-promotion partnership with Novartis France, which is the #1 in ophthalmology in the country. And it allowed us to move from 10 to 15 ophthalmologists up to now 190 active retinal specialists in France and more than 2,400 patients, while having the same retention and engagement figures. So that was extremely interesting. And right now, I think that the next step in France, we submitted what we call an Article 51, which is equivalent of the DIGA process, in order to get a pre-reimbursement in France, and would like to be obviously the telesurveillance platform in France to be reimbursed, the first ophthalmology telesurveillance platform to be reimbursed. Now, knowing that it works really well in France, it allowed us to start having discussion, especially during the COVID crisis. It allowed us to have discussion about international deployment. So you see, it was really, I would say, a test and learn phase, where we first looked at how the market was reacting through our beta test, and to make sure that the product was solid and was working for both doctors and patients. Then we secured the first co-promotion partnership in France in order to make sure that it was working on a nationwide scale. And with the COVID crisis, I think that there was an acceleration of our discussion, and obviously we will be, and this is actually the first time I'll be speaking publicly about it, but we are launching internationally all these sites in the US and in Europe in the coming months. Indeed, in the US and Europe, we are extending our partnership with Novartis. And so using the similar model as France, we'll be launching the product in the quoted countries. But we are also having discussions with, for other countries where the need of remote monitoring tool has never become as high as it is right now. And what we realized also is that we have a unique technology that could be leveraged on other ophthalmology use cases. And so our idea is, now that we know that the product is working nationally, that we are moving internationally also with Odyssite, we're looking at, how by using the Odyssite technology, we can leverage other ophthalmology use cases. And we're diversifying our portfolio of product by creating Odyssite Clinical, which is a monitoring tool for patients that are enrolled in clinical trials, and also Odyssite Home, which is a monitoring tool in order to provide a better visual care for patients that are in residence homes, in care homes. Obviously, I'm open for questions. Thank you for having me, and I look forward to discussing with you all.
A great presentation of your product. I'm curious, and I'm wondering if you can tell us more a little bit about the hurdles you had in implementing DTX in the market, and if you can walk us a little bit through the go-to-market strategy that you had and the challenges in educating the patients and the practitioners.
Yes, absolutely. It's a pleasure to be here, obviously. The one key aspect that once we got our CE mark, and obviously we had the clinical validation, we realized pretty fast that we wanted to make sure that there was good, outcome for both patients and doctors. And so we started to do beta tests, as I was saying in the presentation, in France. And what was important is to make sure that we had engagement and usage from patients, but also from doctors. And what we realized is that obviously it takes a long time to educate doctors on, why and how to use a digital tool inside their workflow. And so partnering with an experienced partner like Novartis helped us understand a bit, what it takes to basically, I would say, implement a new product inside the physician workflow. And it helped us also really realize that we needed to have a distribution that was pretty much like a medicine in the end. Even though we can use digital tools to distribute the product, in the end, the way you're convincing the doctor is pretty much like a medicine. So that's why it's more of a marathon when it comes to acquisition and adoption of DTX than traditional digital product. I would say, coming from the gaming industry, it was very different in that aspect.
Well, thank you very much, Eduardo. It was a pleasure having you. And we're really excited to see what's next for you and what's next in our track during the day. Thank you.
It was a pleasure. Thank you so much. Bye-bye.
Have you been feeling stressed, low, angry, or overwhelmed? Have you considered an online video call with a qualified therapist who can teach you techniques to improve the way you feel? It's as easy as signing up. Choose your package, choose a time that suits you, receive an access link, and you're on your way. Minerva, your health matters.
Hey, thank you for joining us today. We have Dr. Sain Sikafi here with us. He is the CEO and co-founder of Minerva, a UK digital mental health technology looking to transform the mental health scene in the UK. Welcome. How are you today?
I'm really good. Thank you for having me.
Sain, tell us a little bit more about how did Minerva start? What motivated you to start this digital endeavor?
Well, as you know, I've been in digital health for a while now, but by background, I'm actually a GP. And to please my dad, I still do practice and keep up what I'm doing. And, back when we started and I founded Minerva, almost 3 years ago now, I saw that waiting times were almost 6 months from GP referral for therapy, psychological therapy, for things like anxiety, depression, low mood, things that we know 1 in 2 people suffer from, and that just wasn't acceptable. So I teamed up with my co-founder, Rachel, and we set out and building a system and building a national network of therapists that could deliver therapy the same day. Because as we know, the government wrote a report in 2014 saying that by 2020, 75% of people will be seen in 6 weeks. And we know that's not happening. We know that 1 in 10 are still waiting a year. Over half of referrals are still waiting more than 12 weeks. And that's just not acceptable. So we're really proud of what we've done. And, the solution is there and we can see people the same day.
Exactly. Would you say that's the main message that you want to transmit with Minerva and what you're doing right now?
Absolutely. So we've got a pilot in the NHS in Cornwall. It was meant to start with only a handful of surgeries, and now we're already serving a population of around 200,000 people. And we're able to offer them psychological therapies, the same day. And obviously they can choose the time. So, we've blazed a trail and being the first to offer appointments after 5 and on weekends. Previously, people would have to, give excuses to their employer as to, why they had to attend therapy in the 9 to 5 slots that are currently available to them. But with us, people can discreetly and confidentially and securely see a therapist to get help in the evening and the weekends, which we're really proud of.
And from the comfort of their own home.
Yeah. Right? Yeah, exactly. Via live video, smartphone, tablet, laptop.
And how do you see, how do you interpret, or how do you see Minerva has proven itself to be a real solution for this problem, or for all these challenges that you as a GP started seeing?
Well, we know our platform has grown in appointments demand by about 20-fold. We've, as I mentioned, working already in the NHS, trying to prove what we're doing in conjunction with the University of Plymouth to really get some sound data. But we're really proud to be working with universities now by serving their students, including in Europe, students that are alone with no support, attempting to learn another language that needed that support, and that's growing. We've also were approached by global telecoms providers to deliver text-based solutions in the Middle East and emerging markets. And since May, we've delivered over 120,000 paid for messages in emerging countries. And we look to scale that and build an artificial intelligence solution around that as well. And to add to that as well, We're working with the electrical industry charity, where we're providing mental health support to over 1.5 million of their members who work in the power plants and electrical industries in the UK. Those are just some of the examples where Minerva has been trusted with large numbers of people to deliver at scale psychological therapy and mental health support the same day.
No, sounds incredibly interesting. And it sounds like you guys are really trying to make Minerva available for a lot of people, and for it to grow it and kind of like disrupt the whole mental health scene and improve the access and pricing and availability for people to feel comfortable reaching out for help. How do you see that influencing or having an impact within the health sphere as a general, like for having people, to give people more access?
I mean, that's a brilliant question. Accessibility is really the big thing, because the stigma, the taboo, those are still big issues. People, this is a really sensitive subject still, and the longer that people wait, with these waiting times, even employee assistance programs at companies, if you're 1 in 5 people going for a promotion, you're not going to tell your employer you need CBT for your work-related stress. And what ends up happening is the anxiety and depression gets worse. Relationships get broken. People lose their jobs. We know from the data, presenteeism is around 40% in the UK, probably worse now with COVID. People are losing their jobs. Cost to the economy is £99 billion a year. Cost to the global economy is $1 trillion a year, and that's from the World Health Organization. This is public knowledge now. Mental health is no longer a Cinderella subject. COVID, unfortunately, has brought it to the fore. And we're here where people can access it from the comfort of their own homes. They don't have to worry about their employer or their spouse or partner or whatever. They can get the help they need securely and confidentially. They can access our self-care resources 24/7. And, it's really as straightforward as that. So I really hope that we can continue building this, not only in the UK, but globally. We're really proud of the work we're doing in emerging markets. And yeah, that's the key. We want to get people the help that they need, because everyone's got mental health. Just like we've got physical health, everyone's got mental health. And it's about mental fitness, just like physical fitness.
Exactly. Thank you so much, Zane, for being here, for your time, for talking with us. I would like to open this up for our audience in case there's any questions coming from there. Great. We had a couple of questions from the audience going on in the question function. Can you tell us a little bit more about the biggest hurdles in GP adoption? Any pushbacks in the market?
Yeah, so that's a really good question. So at the moment, obviously, prior to our work in Cornwall, we had to kiss a lot of frogs to get to where we are now. So yeah, I mean, it's not been a walk in the park, and still, obviously, there's a long way to go. But I really think that the key to that is stakeholder engagement, which we've done, and building a solution from the ground up by aligning our processes with that of our partners in Cornwall to make sure we're delivering what they want.
Mm-hmm. This market has gained a lot of popularity and attention, especially now with COVID, right? And the whole conversation of how the pandemic has affected mental health in people. How, in your own words or in your own experience, how would somebody differentiate itself within this market?
So I think the really key thing that we differentiate, and what's important to us by listening to all the partners that we're involved with, is actually delivering a same-day solution. So we know and we see that actually with COVID, anxiety and depression and the wait to be seen, whether privately or publicly, has got worse. And actually what's really important is seeing people the same day. And obviously delivering that at a national scale or even international scale, in our case, is very difficult. But that's really what we're proud of, in executing that. And developing that national network of therapists who we're able to call upon to see people when they need them at the time that they need it, through smartphone or tablet or whatever.
And a little bit deeping in on what you just said, what do you see are the main challenges with implementing this solution? Is it mainly stigma around customer adoption, or scaling it appropriately, or getting GPs and like therapists up to date and like familiarized with the software?
I think there are. I mean, exactly. There's going to be on each section. You know, with the NHS, it's going to be, you know, addressing what the government is doing and that promising that there is funding available, but then not actually delivering that support, and actually getting across that it's never been in a more important time to provide an affordable solution like what we're doing, which brings down the barriers. In terms of the organizations and charities and other people we work with, the barriers, I suppose, to scaling that across is really getting them to understand that actually a turnkey solution like this, where we're not just working with the NHS, but we're also working with universities and students, is really important, because any organization that takes mental health support seriously is going to be wanting to think about this solution, where we're no longer talking about DIY, do-it-yourself kind of products, but we're actually talking about real mental health support that's needed. And we're not relying on, you know, for all the goodwill that charities are doing, they're not professional support. Like, you know, if someone were to break their leg, we wouldn't expect them to go and, you know, tie up their leg themselves and get a charity to help them. We'd expect them to seek professional support as soon as possible. And that's really what we're trying to do, to really bring mental health on par with the rest of healthcare delivery.
Thank you, Zane. Sounds like a really challenging thing to do, but an amazing work. I see we have a lot of more questions within the chat, but we don't have time. I just want to encourage everybody to reach out to you, Zane, via LinkedIn, or you can go into the participation page to get all Zane's information, contact, and I'm sure he'll be happy to continue with the questions. Thank you very much, Zane. It was a pleasure to have you.
Thank you so much for having me.
The final of this DTX Focus, it's my pleasure to introduce to you Elena Mustatea, CEO and co-founder of Bolt Health.
Hi, we're Bolt Health. We deliver digital therapies for digestive health. And today I'm going to talk to you about how we're creating new paradigms of care in gut conditions. So digestive illness affects a lot of us. About 1 in 3 will have a chronic GI condition, which leads to a lot of healthcare services utilization and significant spend. About $150 billion annually in medical claims in the United States alone. That's more than in things like accidents or mental health conditions, yet rarely do we hear about innovation in GI. So our mission at Bolt Health is to help individuals around the world manage their gut health, get to restore their well-being through effective and personalized digital care. The first condition area we're covering is irritable bowel function. This is the most commonly diagnosed digestive condition, affects about 15% of the population, majority of whom are women. It's a highly disabling and distressing condition, being the second cause of work absenteeism, and very associated with stress, depression, and anxiety. Even though IBS is so common, it is massively underserved. So if you could, it's actually more prevalent than depression or anxiety. It's more disabling than diabetes. And even though you've seen hundreds and hundreds of startups and companies serving these condition areas, there's barely anyone in IBS or digestive disease more broadly. And that's what we're here to change. So the story of Bolt is that we started in London in 2018. We built our first product, Zemedy for IBS, that is already CE marked. We've run a clinical trial with the University of Pennsylvania on it, and soon are publishing the results. We've already reached 10,000 users on Zemedy and have generated our first B2B and B2C revenues. And now we're already at our second product, Zemi for Children, have gotten Innovate UK grant funding and have a lot of other exciting projects underway. But today I'm here to talk about how we're making a difference in digital therapeutics. And there's 3 main areas of innovation: product innovation, doing research differently, and covering condition areas differently. So first of all, in product innovation, Zemedy is the world's first CBT-based digital therapy for IBS. And there's three things that we've done really differently in product development. First of all, we went for a cognitive behavioral therapy intervention that is low intensity and proprietary, developed at University of Pennsylvania. We have worked with digital CBT experts that know very well how to take a face-to-face intervention, transfer it to digital, and we've done extensive patient testing. We've had 3 MVPs over 2 years with 10,000 users giving us feedback and constantly learning. And that allowed us to develop a delightful and deliver a delightful experience with beautiful user interface and good UX, with millennial-friendly, sleek design that people love to use. It's a bit like their Instagram. Then we have a conversational interface. This allowed us to add that human touch of healthcare with a virtual assistant that understands IBS very well and can guide the patient through their care journey the way an IBS nurse would. This allowed us to have one of the best apps in the App Store, not just one of the best digital health apps. So we've been featured already 3 times in the very first month of relaunching the app in October. And now, just to give you a bit of a feel for the app. And IBS is just the beginning. We're building a scalable platform where we can use a repeatable formula for success in digital therapeutics, in digestive care. We already have a second product, as I said, and next year we're working on an IBD product. The second area of innovation is in research. So we've leveraged historical clinical results from University of Pennsylvania, face-to-face and in a self-care setting. And then we ran a clinical trial on the digital format of Zemedy, 120-person RCT. We did this completely virtually, a decentralized trial where we recruited people online, emailed them, did the questionnaires online and consents and so forth. And that allowed us to go straight into an RCT, a pretty large-scale RCT, to go much faster, 12 months, all in to submitting the paper, and we did it 10 times or more cost efficient. Thirdly, we really care about our patients and we want to cover and serve as many as possible. So it turns out children get sick too. Most digital therapeutics will target adults and serve adults, but we really love children as well. And we learned that 20% of children suffer with a very common digestive condition called functional abdominal pain that really affects their mental health as well. Majority of the sufferers will also have depression, anxiety, and it really affects their school performance, their health outcomes later on and so forth. So a very, very big issue, but it turns out there's no digital app for children's digestive in the App Store. So we decided to change that. We created Zemedy for children's functional abdominal pain, a completely different journey from the adult CBT program. It's based on guided imagery, it's very friendly to children, it's more of a story, very visual, very audio and interactive. So in conclusion, this is hopefully it gave you a good idea of how we're innovating in digital therapeutics and how we're creating new paradigms of care in gut health through product innovation, research innovation, and covering children's gut health as well. Thank you very much. Very happy to talk more. And lastly, we are raising a seed round. So if you're interested in investment as well, please do reach out at elena@bold.health. Thank you very much.
It's unfortunately Elena cannot be with us today live to answer all the questions, but she did leave her email address for everybody to feel free to reach out. Next, it's my pleasure to introduce to you my good friend, Annalena Lawrence. She is connecting with us from Germany. She has an extensive background in digital innovation and in human-centric design, and she's responsible for curating this amazing track. So join me to give Anna a warm welcome. Anna, on to you.
Thank you, Valentina. I'm here. Welcome also, Adam. Super glad to have you. Just as a quick intro, Adam brings an extensive view on this whole market. As a health economist, went on to spend some time in designing health promotions, but turned entrepreneur. So as a pioneer in the field, he's seen the market really develop. He went or something over half a decade ago, he went on to found Canary Health. It's a leading provider of digital self-management programs, where he's now the chairman of the board. And he's also heading up this newly formed Abundant Ventures partner and Boston Consulting Group joint venture, DTXL, focusing uniquely on digital therapeutics. So welcome.
My pleasure. Thank you.
So super glad to just dive right in. We just talked a bit about digital therapeutics and how they differentiate themselves from others. So we've seen in other digital health tools a big increase and a push and amplification through the corona pandemic, such as telehealth visits increasing by over 150%. Yeah. What's your take on that for digital therapeutics? Has this been a good or a bad year?
Yeah. So, I mean, I think almost entirely good, with one caveat I'll get to in a second. But I think, and we'll probably talk a lot about the infrastructure of digital and healthcare that enables digital therapeutics. But, you know, we need consumers who want digital. We need providers who understand and are willing to do it. We need payers that are covering it. And so while most of that activity, as you're mentioning, is in telemedicine and other sort of areas of digital health, it only moves, you know, the whole industry forward and really lays a foundation for digital therapeutics to get more broad. The one caveat I'd say, we saw this at Canary and in other places that I'm close to, you know, a lot of digital therapeutic companies are still relatively early. And one of the challenges of the pandemic was a lot of bigger companies that would be your partners or clients had to put new things on. So I think, you know, there was a little bit of a phase of maybe, you know, some of the stuff that we were working on. The way I describe it is, if you already had a contract, it was only good. But if you were trying to get new contracts or run new studies, it may have delayed you a little. And so I think there is a little bit of you know, we're going to have to figure out how to get some of that momentum back in some areas. But from an industry standpoint, in terms of demand for the products, understanding of it, regulatory pathways, you know, what people were saying about telemedicine, we covered 10 years in 1 year, I think will be true for digital therapeutics as well.
You already mentioned a few things. Let me dive into that a bit. I mean, when you look at it, the digital therapeutics market is estimated to grow quite a lot and poised to become a $9 billion market. So what are these enablers? What are the things that need to be in place to actually make this happen and that made it happen to grow as much as it did already?
Yeah. So, I mean, I'm very bullish on it. Obviously, I've spent my career, you know, for more than 15 years in what are now called digital therapeutics. When we started, that name didn't exist. But, you know, as a reminder, you know, a $9 billion segment of healthcare is still a really, really small segment, right? There are single pharmaceutical double that. So we should be really proud, but I don't think that in and of itself is the goal we have, right? It's really to disrupt healthcare. It's to take digital's ability to scale, to democratize access, to, you know, essentially engage folks with stuff that is less dangerous maybe or less side effects than pharma and device, and really change a paradigm. So I just want to say, like, yes, it's going to grow tremendously, but that number is not the end. I think the biggest is the infrastructure of digital that enables a digital therapeutic company to have a way to be prescribed, has an acceptance of a consumer, has a way to be charged. When we started in digital health and digital therapeutics, as I said 15 years ago, you really had to build almost all of this. You had to figure out, how did you live in the EMR or the claims-based or health plan-based application? You had to figure out what the consumer was. We were inventing payment models. And so a lot of that has flushed itself out. We still have a ways to go, but there are companies that do nothing other than how do you prescribe digital therapeutics, and there are digital formularies that are starting to do. I think that industry infrastructure, that means we can be great at the software that engages the clinical outcomes and not have to worry about all the other pieces. It's really the biggest step to enable that growth.
Yeah, I have a follow-up, if I may ask here on a bit of a detail there. So it seems like a lot of these components rely on each other. So is there one where you said that that's the beginning, the foundation, of it, to actually have these others fall into place, such as prescription, payment models, etc.?
Yeah. I mean, it's an ecosystem, right? So I think your question is a good one. Is sort of, if I have to pick one part of the ecosystem, what would be the most? I think, and it'd be interesting to get, I'm sure, other panelists and other discussions with this group, but I think at the end it's the consumer acceptance. Mm-hmm. It's the understanding that digital therapeutics drive outcomes that are meaningful for consumers. They're willing to use them, and they're willing to think of them in the class of therapeutics more broadly. Everything else comes from that, right? If we don't have consumer interest and we can't demonstrate engagement and outcomes for consumers, no one's going to cover it. No one's going to prescribe it. I think that's probably the biggest change. If you allow me a little bit of looking back. So again, when I first started in digital health in 2004, in some ways it feels like a long time ago, in some ways it doesn't. So this is pre-Fitbit, this is pre-iPhone. I mean, there wasn't even a consumer infrastructure to do these things. And we were building programs, taking what were called actigraphs, which were the research quality physical activity monitors. You had to write the direct SDK yourself to pull it in. There wasn't a phone to display it on, so someone had to then go to a computer and plug that cable in and look. I mean, the consumer experience in consumer digital just, is light years away from where it was when we started 15 years ago. So I think that's the foundation for all of this. The B2B infrastructure will come if people benefit from it and are looking for it.
Now, when we stay all the way in that time, all the way back, digital therapeutics wasn't the term. Even digital health was kind of, a new thing. How did you perceive that adoption, so to speak, and what was the biggest challenge in changing patients' or consumers' adoption in that sense?
Yeah, it was hard. I mean, I think some of that is where we're still living. I mean, most digital therapeutic companies had, while there's various ways to get paid, and some are direct to consumer, and some have managed sort of enterprise structure in contract. Most of us are still B2B2C. So you have to get an enterprise to agree to do something, but you really don't get substantial revenue and impact until consumers use it. And so, figuring out those two constituencies and aligning them is really hard. I think, your question specifically around, what did it take for consumers to see digital as, on par with other therapeutics? I think a lot of that has been what we were talking about before, the growth of just digital technology and its pervasiveness in our lives everywhere. But also work that a lot of folks have done, some of those companies here, to show that these things work and that there is a real evidence base. And it's not just an app you can download somewhere, but that, rigorous trials and rigorous clinical evidence really on par with what you'd expect from pharmaceuticals or med device to demonstrate that there's efficacy. And it took a while. I've been in conversations that have been evolving from hey, no one will do that. It doesn't matter. Digital can't do any impact to. Well, that's really interesting. You still have to prove it to us, but the burden, the belief that it can work is there, and now you have to show that. And a lot of energy went into running trials on digital tools that aren't natural, set up for the way we run randomized controlled trials for small molecules or biologics. It's a different kind of product. So I think that's probably the biggest thing that's driven digital therapeutics.
Yeah, I'd love to actually dive a little deeper there. I mean, so we're coming from this consumer adoption as a key challenge, right? Where was this shift, if you could elaborate a little bit, of saying, okay, we do want, whether like it is a D2C or a B2B2C, but we do want to look into actually generating clinical evidence and then also going on to doing that?
Yeah, I'm not sure if it was a shift from those of us doing it. We ran our first IRB approved clinical trial and published a paper in 2005 looking at promotion of physical activity with a digital program. So I think that the scientists and, my experience, and I think for a lot of digital therapeutics companies is similar, is, let's find great programs that have been proven in academia. So, academic researchers have been running research on digital for decades, right? Because for them, it's about, translating science to the bed. It's about driving impact. So I don't think it was a shift in we needed to run studies. I think it was a shift in the providers broadly and the payers broadly to say that actually that evidence is meaningful and I believe it and I trust that can drive outcomes. And some of that came from folks doing work on what are the kinds of studies that should be meaningful. I mean, I think a lot, it took a while to figure out what was the kind of research that would matter in this space. The story I tell is that first study we ran that I was referring to that we published in 2005. It was a 12-month outcome study. So it takes 18 months to run that trial. The web browser had been deprecated, right? So there's some underlying work we all have to do to be like, okay, how do you actually talk about digital? It evolves at a different rate than certainly pharma, but even med tech. And so what did it mean to have evidence? But I think there's been a shift as we've just done more of that, and it's been pervasive that people believe they can work. We still have to prove that because not everyone does. So I think that's been more the case, and it's been chipping away at it for a long time.
It does. It always grows at a slower speed than you'd expect, I guess. What kind of doors did that open? I think you alluded to some already with payers or providers when you brought the evidence. How did that change the pathway, so to speak, for your product to actually get into patients' hands?
Yeah, no, it's a good question. I appreciate it. Give me 1 second. As you can hear, I'm trying to turn off my email so I don't hear these sounds. Sorry. It's the penalties of being remote. I obviously wish I was with you all in person. So let me just get that off so you don't hear the beeping. The doors that open. So, I still think, and this is true, my limited experience with other therapeutic categories, you have to have people who believe that this is something that benefits the lives of patients. And you need champions who understand that the digital therapeutic, whether it's based on behavior change or cognitive behavioral therapy or, sort of changing neural synapses by what it's doing, that is meaningful, and they sort of believe fundamentally in underlying science. What you find, though, in sort of the buying behavior, for lack of a better word, what I found from the buying behavior of health plans and providers is that champion can't make a decision on his or her own. They've got to go convince another group. And it's that evidence base that allows them to go to the other folks who I don't even want to say are necessarily skeptical, but they're not bought in yet, right? Let's say they're at best neutral. And so they've got to come with, not only do we believe this works and here's consumer demand for it, but here is evidence that supports it to move the rest of the organization. So it really was, you could get pilots, you could get early adoption with just sort of passionate people who came along the journey with us. But if you wanted to move an organization at scale, you wanted to get the folks who commanded bigger budgets, who made decisions across therapeutic areas, you had to have the evidence. And that's really what we've seen and are seeing in the last couple of years is moving beyond that initial pilot with a champion who believes in it to, broad, sort of population rollouts because the evidence convinces the rest of the organization who has to get behind it.
Yeah. Honestly, on that, or like as a follow-up, maybe as on the partnership question here. So whether that's with providers, payers, pharma, medtech, there's a big, or like lately, lots of partnerships popping up, investments popping up, etc. So there's definitely a development here lately. Now shifting a bit to today's view. What kind of changes can we see over the course of the last years in these partnerships? What are the key things that have popped up? And maybe as a second question there, what kind of role do they play in making this happen for patients?
Yeah, I think the partnerships are really exciting part of the story. If I come back to that idea that when we started this is true, and the economist in me who sort of studied industrial organization in general knows that new industries tend to have what we call vertical integration, right? So, the early players in the industry kind of have to do everything because it's not clear where value add and how you segment it out. The real maturing we've seen over the last couple of years is that it's clear where value is being created and who's good at what. And so I think, some of what you're referring to are these large partnerships between digital therapeutic companies and pharmaceutical or med tech companies. And I think it's really positive because what you're seeing, and what I think that means is the recognition that the capabilities to build, to test, and to sort of run digital therapeutics are unique and are important and valuable, but they can fit into some of the capabilities that these established companies have in terms of how do you go to market, and how do you sell, and how do you scale. And before you would have had to have kind of done all of it. So I think what you're seeing is partnerships that recognize value created across sort of different points of the continuum, or for lack of a better word, maybe the DTX life cycle, and partners saying, hey, I'm going to be really good at this, and you guys are really good at this, and together we can do more. And really, that's the only way, right? Healthcare is so complex that if every digital therapeutic company had to, build their own quality management system, had to, do the original science, had to build the technology, had to then build a commercial organization, we never get there. And so you can see this in biotech and pharma, right? A lot of the small companies, their models are get to certain stages, and then the big companies support commercialization, or they outsource the clinical trial itself. So the fact that digital therapeutics is living now in this broader ecosystem speaks to me directly to the maturity of the core capability in digital and digital therapeutics to live inside of the infrastructure that we have for other things.
You mentioned the ecosystem. Is there a particular change or a shift of dynamics that all of these partnerships have created in the larger ecosystem?
Yes. I'm trying to think though on the best dimensions. I mean, I think the most obvious one, which is more just the scale and acceptance, is that when you have Fortune 50 pharma companies committing real resources, points to the maturity of the industry, the expectation that digital and digital therapeutics are part of the therapeutic landscape. That speaks more, as I sort of said, to the maturity. I think if your question is around sort of what does this say about the success of things, I think it really does speak to what I was maybe saying a second ago, which is you don't have to be great at every part of the continuum anymore. You can focus on the pieces that are really distinct and add value. And for the most part, for those of us in digital therapeutics, that's a combination of sort of what is the translation of science into the digital application? How do you continue to build and operate that? And then where are the places it creates value? And then there's other players that can help you scale that from a commercial standpoint, can help you run the trial, can help operate it if that's the platform that wants it. So I think that's probably the most important. And it speaks to the recognition that core digital asset, right? If you think about therapeutics, pharma thinks about molecules as an asset, or biologic as an asset. And, we're not maybe quite there, but I think we can talk about sort of that digital therapeutic kernel as the asset. And now it's a question of what's the ecosystem and infrastructure that develops it, tests it, and takes it to market.
Let me ask a question, and you tell me if you think it was part of the one you just answered, or if it's a different answer to that. So before digital therapeutics became this hype and thing, and the ecosystem being what it is now, was it easier to build your business and to bring it to patients, or has it actually now heard that now that lots of companies are in the DTX space?
Yeah, it's a good question. I don't think competition among DTX companies is the primary challenge, if that's sort of what you're asking. I mean, one way to think about it is what we were just, what we said earlier, which is even with aggressive growth, the entire DTX industry will be half of what Humira does in a given year, right? So it's not that we're beginning to crowd out folks. I think what has happened, and I think this is a positive thing, I think early on, before the industry had matured some and it was less clear what it was, in some ways it was easier to get initial pilots. And so I think you had a number of companies that had sort of false starts in the sense that they got something that one or two clinical organizations at sub scale were able to do, but they weren't able to actually then scale that. And so I think it is harder to get those initial things because there's more understanding what success means and there's more rigor. But in general, I think that's good because I think it means we're weeding out companies that don't have great science or great products or great development earlier, enabling those that do to capture more of it. So there's too much noise in the market and too much inability to sort of differentiate. It does actually hurt everybody. So as we get greater clarity and more standards, it's harder for any one company to start, but I think it benefits everybody who's doing it with rigor and excellence because as long as they're adhering to that. So it's a little bit of yes but I think ultimately it's good for the companies that are serious about it and in the industry as well.
Yeah, let me ask you there. Where do you think we are with this rigor and understanding of what it needs, what the infrastructure like basically today? What are things that we're lacking still, or that you see are in the process of being built?
Yeah, so I've always tried to think about it sort of from the life cycle of a product. So I think if you start with sort of, what is the conceptualization of the product and the building of it, I think we will always get better with the actual digital products, and we're not quite, as an industry, I say, and hopefully the other panelists will agree with me, or the people in the audience, that we're not quite at consumer grade across everything. But if you look back in 5 years compared to consumer grade, we are much closer, right? So the products themselves have gotten much better. The expectation of evidence and what it means to collect evidence is much clearer. So that's sort of the first phase of the product lifecycle. So I'd say we have a little bit more maturing, but we've closed the gap between consumer expectations pretty fast in digital therapeutics. I think the clinical trial, the validation has come a long way, but maybe not quite as far. I still think there's some questions about, what are the right trial designs for some of this? What do you do as a placebo? Do you put a fake thing in front of somebody? Where do you need a randomized control trial or not? But we've come further, but I think we'll flesh that out further. I think the regulatory frameworks are evolving, but seem to have come a long way in the last couple of years, certainly in the United States. And coming back to your first question, the pandemic has been part of that. I'm not as familiar, but I know obviously Germany has made big steps in terms of what it is. I think the place where there's the least, say the most to grow is really in the coverage and the commercialization.
Okay.
And because digital therapeutics are pursuing multiple pathways to market, right? There's not a digital therapeutic benefit that's been established in a known pathway to market the way there is for pharma or med tech. You've got the right kind of experimentation. So some are saying, let's go DTC and then build value. Others are embedding in clinical care. Others have embedded as part of broader digital health solutions that look more like remote patient monitoring. Others are going very much after, a prescription model with, regulated product that look like pharma. And so I think, that's natural and that's healthy. But as we can be clear on what are the pathways and what are the different kinds of DTX that get that, that'll help make it easier to build and scale. So it's really in the commercialization. I don't think I'm saying anything controversial. I think most people would agree that that's sort of the frontier that we're at this point.
Yeah. Is there a key difference, there's a few players that we see that have a D2C and a prescription model, for example, in parallel. Is there a key difference or like in that commercialization that they to consider, so to speak?
I mean, absolutely. I think it's small. I mean, so there are some, digital solutions that could be digital therapeutics, that never really should be, like they won't deliver clinical outcomes that are meaningful, but they're meaningful to consumers. And so that, they probably should stay, direct to consumer solutions. There are some that have to be regulated digital therapeutics because they're doing things that, are medicine-like. So, good examples would be digital therapeutics that are dosing insulin. Like you can't have a consumer version of that, right? That needs to be regulated. And then I think there's a large group in the middle where, you can attach human clinicians and you can remove some of what will eventually be automated in the digital program and deliver it as a tech-enabled service. And then, there's a pathway. I think it's a very smart strategy, right? It's a combination of let's evolve the product so that it doesn't have the necessarily clinical rigor that it one day will. And a good example would be we're going to have human beings doing some of this in the background. They're going to be licensed clinicians, but you can build proof of it, an evidence base, and then sort of, test in the background and develop some of the algorithms that ultimately get automated, that ultimately allow you to get, a digital therapeutic that moves from it. So in general, I think it's a smart path, but it does depend a little bit on sort of what the structure of the is and which disease states. And obviously practicing medicine, it's got to be, you can't go direct to consumer from the beginning.
Fair enough. I mean, there's also this thing of like, if we look at how did digital therapeutics came to be, where did they start, right? Of like mirroring an existing model and taking that digital. Now we're at a point of maybe we can go straight to a digital new model, right? So what are the key qualitative aspects that you would be looking for in now maybe from your new DTXL lens as well? What are these key things that you would want to see in a DTX that's starting?
Yeah, thank you for that. So, at DTXL, we're stepping back and sort of thinking about what are the right places to build digital therapeutics. And I don't want to sort of oversell the rigor of this, but we've got a framework that starts with, kind of what does it take for each of the constituents. You can imagine as I'm talking sort of a Venn diagram that has sort of each of these constituents, and we're obviously the places overlap. So for us, if you start with the consumer or patient, it has to be something that's meaningful to the patient that they're going to care about. And it seems obvious, but we all know certain conditions that are not apparent to the consumer. So, hypertension is often a good case where it's meaningful clinically, but if the consumer isn't driven to do something, most digital therapeutics require engagement. So for us, it's let's look at places where the consumer would care about this and be benefited directly by doing it, not just long-term health outcomes, but so then we think about the clinicians and we say, okay, well, this has to fit into their workflow and the way they practice medicine. And that's a little bit nuanced because in some cases, clinicians want the patient to come into their office more often, and sometimes they don't, right? Like, so it almost depends on how they're compensated and what their practice is. But now as you look at disease states and say, okay, let's talk about, outcomes or, things that matter to patients in a particular disease. Now we can look at does it matter to the provider and does it matter in a way that, they're going to be incentivized, and that doesn't mean financial incentives, but from a workflow and the way they work and fit into the way they practice medicine. Then we think about the payers. So what would they care about? Is there a quality score that we think we can drive with this? Is there cost reduction? Is there, a complementarity because things that matter aren't being used, so it's really an adherence play? Is it going to replace another more expensive therapy? And then we do think about pharma and med tech and the other, therapeutic companies because, a digital therapeutic that complements or a digital therapeutic needs to fit into the ecosystem of how care is practiced for that, right? So, there is a pill that has little side effects, is relatively affordable, and solves it. Why would you build a digital therapeutic there? On the other hand, if it's a meaningful medication, but it has significant side effects, maybe that's actually an opportunity to support the reduction of those side effects. So we really try to look for areas that cover all of those. And as you can imagine, there's not a lot, and unfortunately it's moving, right? As new drugs come out, what matters in pharma, as payment models for providers change, it changes consumer taste. So, it's a dynamic question, right? Anticipating a couple of years from now as we move through the life cycle, what will be the state for all of those constituents?
You already alluded to all this dynamics going on right now, and with the growth period that we're experiencing, let me close this off before giving some time for a Q&A as well. Who do you think are the biggest winners right now in this growth stage, or maybe in the next few years to come?
Yeah. So I'm without mentioning names, because it wouldn't be fair to those present, I'm particularly excited about digital therapeutic companies of two types. And I think the risk, and they're almost at two polar opposites. And I think the risk for some companies, and I've seen it, and maybe was guilty at it at Canary, of trying to be in the middle. So I think companies that are super, super focused on a digital therapeutic in a category where you can almost say this is the best therapeutic, period. Like, you don't have to say this is as good as pharmacology or complements, but like, this is what we should treat patients with. Categories like that, I think, are like childhood mental health conditions, where often there isn't good pharmacology, or if there is, it doesn't do everything, or sometimes parents are scared of it. And you're not sort of saying like, hey, we're a digital therapeutic, look at us, but like, we're just the best therapeutic for that. And I think just hyper focused on building that product, getting it to market as, sort of a single monotherapy in that category. And I think we'll see some real winners in some of those categories. And so that's one end. And then the other end, I think, are the companies that have, be able to bring in the capital and the resources to really treat it as a portfolio and a platform, and invest in the infrastructure across multiple therapeutic areas. So the core operating is sort of more efficient than any one vertical. And then as they gain expertise and experience in detailing docs and getting prescriptions, they can spread that across. And so, if I were, sort of advising digital therapeutic companies, I'd say, you're likely going to have to fit in one or two of those, right? So if you've got kind of a small portfolio and it's not in sort of, super niche areas, like, try to find a niche or grow to be the whole thing, because like, you're not going to scale by just being the best therapeutic, and you're not going to have the scale in the short run to make the investments.
Yeah, focus is key, or the breadth it is. Nice. Cool. Let's take a look at some questions coming in. And thank you so much, first of all.
Oh, it's been my pleasure, and I look forward to answering the questions.
To have you here to answer some of the questions. We got some in through the chat. So I want to start with the question that we got in about the regulatory environment and how you would see them or that environment impact the ability for these digital therapeutics to scale.
So I've been impressed with the regulators actually in some ways being ahead of some of the industry. I mean, in the US, the FDA has made it a priority to figure out digital. They've been at the cutting edge. I actually was part of an NIH group in 2008, 2009 that was looking at how do you design studies for digital. So I mean, it's a big part. I think if I'm remembering the question as it came in, it was also a little bit about, will regulatory make it harder or easier, and how does it compare to other industries? I think health regulation is a little bit different in the sense that, or I think the question was maybe around fintech as well. Most of healthcare, even if the regulators weren't involved, is still mediated through clinicians. And so the regulatory framework provides guidance to the clinician to make decisions, and big health systems and hospitals don't do things that aren't regulated. So it's a little bit different in other areas where regulation is standing between the industry and directly the consumer. And so I actually don't think they'll be limiting what we want to do, but actually enabling it.
Maybe that leads me to the next question here. There was one around big tech. And I mean, big tech is famous for being so focused on user behaviors and patient centricity, essentially. Yeah. Do you believe that their speed could jeopardize the overall quality of digital health tools, and especially the safety and efficacy for patients?
I think think it remains to be seen. Big tech at this point, I think, are playing really important roles in some of the infrastructure. So, as we talked a little bit about sort of this ecosystem, before you'd have to build out the full tech stack. It wasn't even clear. I remember when we started, none of the cloud service providers would sign business associates agreements, so you couldn't actually really host on them. And they've come a long way in actually providing infrastructure that enables the security and enables a lot of the foundational stuff that would have kept it. So I don't see big tech today on that sort of last mile of the therapeutic. It remains to be seen, but I think today and probably for the near future, they want to be very involved in the infrastructure pieces and the enablement and ensuring security, which I think is important for all of us because none of us have the resources to really stand up, that infrastructure that's needed at scale. I get the spirit of the question. The move fast and break things motto of tech doesn't work in healthcare. But I think if you look at what Google's done with Verily, first, they haven't necessarily been any more successful than anyone else, and sometimes less. But I don't think they've broken healthcare in the way others might. We'll see. I think it'll happen in other categories. Distribution's a more natural one, so we'll see what Amazon Pharmacy does. But I don't think DTX is necessarily going to suffer, and at least in the medium term, will only benefit from big tech looking at healthcare.
Maybe a related question here is about, so we see consolidation happening, and how do you look at partnerships with these horizontals in this sense, especially also as an example, big tech, and how are we making sure that that's future-proof?
Yeah, let me answer, but I'm not sure I'm answering the question in maybe the spirits there. I think if we looked at the panelists from the VC firms, and you looked at sort of what is the biggest challenge to building digital therapeutics today, it's getting that ongoing funding in, as we heard, right? So it's getting the startup funding, it's getting this, and the biggest reason funding has been harder than it needs to be is we haven't had as many exits as we'd like. So at least in the medium term, I see the consolidation, the acquisitions, all as good indications of the maturity of the industry. And as proof points that it's worth investing in it, and far more companies starting out will get funded than the few that consolidate. Now, one day it will likely be an industry like any big industry that has not a huge number of players. But I think what we'll see in the short run is this actually, the acquisitions, the exits actually make it easier to start more companies. And we'd love to be at the point where, it's a multi-$100 billion industry and, there's a dozen or 2 dozen, international players who dominate it. But I think we're a long time from that.
Okay, perfect. I want to close it off now and move on to the next point. But of course, the chat remains open for any further questions. Thank you so much.
My pleasure. Thank you all.
Thank you.
Thank you, Adam and Anna. That was really interesting and really helpful. I think it gave a good closure to what we've seen up until right now. We're gonna take a 10-minute networking break. So go get yourself some coffee, relax, get settled, and we'll see you in a bit. I want to encourage everybody to reach out to one another and get the networking going. Thank you. Welcome back, everybody. Hope everybody had a good break, that you have your coffees with you, because it's time to continue with this incredible conversations and the DTX focus. Next for the agenda, it's my pleasure to introduce to you Dom Rabin from Explorer Health, that it's an award-winning platform that empowers, engages, and informs young oncology patients.
So the first thing a child does is create and customize an avatar, and they can customize their avatar in any number of ways. I'm just going to change a few characteristics here. And we'll maybe put some hair on and some clothes. You can see my avatar's having a quick floss. I'm going to also show you in the accessories section, we can also have our avatar sitting in a wheelchair if we want, or very topically wearing a face mask. But I'm going to go with a stethoscope and tap done. Now, just before we get into the main body of the app, whenever you see a red balloon in the app, it means that we can see either our avatar or an interactive in the real world. So I'm just going to tap that red balloon. and you'll see there's my avatar exiting through a door, and now you're going to see that red balloon appear on my kitchen table, and as soon as it turns green, I'm going to tap it, and there's my avatar stood on my kitchen table. And this is just about making the avatar feel real to the child. So I'm going to go back into the main app now, and I'm going to go up to the hamburger menu, which is top left, and talk you through the main features of the app. So if we go to the top of the dial with a picture of the clinician, it's really confusing whenever a child goes into hospital, whenever anyone goes into hospital, understanding who everyone is, what they do, and why they're all standing around your bedside. So here we have a whole load of avatars of the staff roles that you're most likely to encounter, and this list is customizable through our management system. So let's say we want to find out what a radiographer does. What we can do here is we can customize the look of that radiographer so that they look like our own radiographer. So I'm just going to change a couple of characteristics, and let's say my radiographer is called Susie. And this helps the child remember the names of the people who are looking after them. So I'm going to tap OK, and if I go back through the list, you can now see that Susie's appeared in the list, and I could go on and customize all the others if I wanted to. So I'm going to go back to the menu, and I'm going to go around to the next section, which is the treatment section. That's the purple circle. And here we explain a whole range of complex treatments. I'm going to show you the MRI. So here's a model of an MRI scanner. If that orange glow, whenever you see an orange glow, it just means you can tap something and find out what it is. I'm going to press the forward arrow, and now we can see an exploded view of the scanner, and I can tap around the scanner and find out what all the component parts do. And if I press the forward arrow, the scanner comes back together, and in a second the control room is going to come into view, and in the control room is a monitor. So if I tap that monitor, I can now see what an MRI scan looks like. And if we were to go on through this treatment pathway, it would explain about the noise the MRI makes, and we'd be able to listen to that and so on. But I'm not going to do that. I'm going to go on to the next section. And I'm going to go round to the environments, which is this icon of a hospital on an orange background. And here we have a range of hospital environments. Let's say we want to see what an operating theatre is like. And I'm going to show you this in augmented reality. So I'm going to tap the red balloon. And again, you'll see the red balloon appear in a second on my desk. And I'll tap that when it goes green. And there's the operating theatre sat on my table now. And I'm looking around the operating theatre by moving the iPad around the model. And I can tap various things within the model to find out what they are. And you can see there's some avatars wandering around the environment, and I can pull back out and come out of there. So I'm going to now go on to the next section, which is the games. Now we have a whole range of games here, from games about bedside patient monitors through to games about proton beam therapy. I'm going to show you one called Plasma Patrol. Most of these games are multiplayer. This is a single player game. The object of the game is to collect platelets, vitamins, iron, lymphocytes, and chemotherapy, to destroy cancer cells, and to avoid white blood cells, pathogens, fat cells, and dead cells. So let's see how that's played. So there's my avatar running down the hospital corridor. In a second, they're going to jump in a spaceship, and then we're going to see them in the bloodstream. So here we go. 3, 2, 1, and we're off. And I control the rocket with my finger down here, bottom right. Those blue things are white blood cells, so I need to avoid them if I can. But I'm looking, oh, I've just got a white blood cell. And another one. That chemotherapy over there, if I can get that, gives me a power up, but I think I had some collateral damage with some white blood cells. So I'm going to quit that game whilst I'm ahead. But if I'd finished it, I would have achieved a high score, and that would have been submitted to a leaderboard. And just before I go on, you might have noticed that my avatar is always present bottom left of the screen. So if I tap my avatar, I can always ask a question. And to do this, we've built our own AI system that uniquely understands the way children misspell words. So let's say I want to know if my operation is going to hurt. It understands my atrocious spelling and gives me a choice of answers. So is my operation going to hurt? And there's an answer. So So I'm going to close that and go back to the menu. And now I'm going to go right the way around the dial up to the calendar at 2 o'clock on the dial. Now our calendar works in conjunction with our management system and our parent application. Parents can enter calendar events in our parent app. Clinicians can enter calendar events in the management portal, and those events will appear here. We can also bring in events from hospital appointment systems, and the child can add their own events by tapping this big plus button. So let's say I've got a scan coming up, and it's asking me to categorize that event. The reason it's doing that is because the categories work in conjunction with our AI system. So if I was to say, when's my next treatment? It would say, you've got a scan on such and such a date at such and such a time. I'm just going to save that event down. And you'll see that event has now appeared in my calendar, and it's got a question mark next to it. If I tap the question mark, I can record how I'm feeling about that upcoming event. So let's say I'm feeling nervous. Now that information is played back to our management system or sent directly to the patient record so that clinicians can monitor mood change over time. And that's a very quick tour of Exploro's main features. I'd be very happy to take any questions. Thank you.
That was an incredible video. Thank you so much. Super, super interesting. We have a few questions, and I would like to start with how has the clinical validation been for you? What was the process like? Any hurdles or specific hurdles you want to talk to us about?
So the process was really pretty straightforward. It was a clinical validation last year involving 80 children, 40 with access to standard healthcare information and 40 with access to Exploro. And what the researchers found was that those children who had access to Exploro demonstrated a statistically significant reduction in procedural anxiety, which was great. The process was, I guess the hurdles of getting ethics approval and all that kind of stuff were largely dealt with by our research team, or by our research partners, I should say. So they were their hurdles, not mine. There were no real hurdles in the study, though. The study went really well, and from our point of view, it demonstrated exactly what we needed it to demonstrate, which is that Exploro reduces anxiety, increases procedural knowledge, and increases patient satisfaction. And what was really good about it as well was that the same results applied to parents as to children.
That's amazing. So interesting. The second question I have here is, you mentioned management platform access for medical doctors and parents. How have, in your opinion or in your view, how have doctors adopted the tool?
So the management portal, our intention with the management portal is for doctors to log into it as infrequently as possible. And that's mainly because doctors have so many platforms to log into already that they want everything in one place. So what we're doing with patient captured information, so patient reported outcomes, mood diary entries, that sort of thing, is sending that information directly to the PR. And the management portal then is largely a user management system. Although that data is surfaced in the management portal, doctors don't need to log into the portal to see it. They can see that attached to the patient record.
Okay. We have time for one more question. Obviously, children are the target here, but it seems like a great app for adults as well. Have you seen adoption with both adults and children alike, or do you see expanding the target audience to adults as well? What are your thoughts on that?
Yes, so we definitely see expanding it to an adult audience. Our long-term goal is to deliver the platform for any patient, any age, any condition, anywhere in the world. We have plans within the next 12 months to do a teenagers and young adults version as the next logical step to broadening it out as a platform for adults. But I should say, my business partner's wife had her first MRI scan last year, and she used Exploro to familiarize herself with that process. So it's already, in a very small way, being used by adults.
That's amazing. Well, congratulations, Dom, and thank you so much for being here and walk us through the app. It was a pleasure.
Thank you very much.
For the last of our focuses, it's my pleasure to introduce to you Chris Wasden, who is the head of the Happify's DTX unit. Chris, we're on to you.
And today I wanted to share with you some of our journey around entering the digital therapeutic marketplace and some of the presumptions we had when we started and where we've really ended up based upon our assessment of the market opportunity. We had been around since 2013 as a direct-to-consumer digital therapeutic business, and then we went into the health plan and employer market. But it wasn't until 2018 and 2019 that we actually began to explore the prescription digital therapeutic marketplace as a result of a number of different transactions that we looked at. We looked at what Pear Therapeutic had done with Novartis as a partner, where they had raised in 2018, 2019, $114 million that year. We saw that Achille had raised $68 million and had announced a big deal with Shionogi, a Japanese pharmaceutical company. We saw Click Therapeutic announce a big deal with Otsuka for $19 million. And we saw that these companies were all doing deals with big pharma companies that looked like they were over $200 million in size with $10 million of upfront fees. And so we began to look at the pharmaceutical landscape and tried to understand where we thought pharma companies wanted to develop relationships with companies like us. And whether or not it was on the left-hand side, which we look at as tactical, versus the upper right hand, which is very strategic in nature. And indeed, these prescription digital therapeutic opportunities were clearly on the upper right-hand side. These deals in general looked like they were around $20 million of value, and they would take 36 months in order to bring a new product to market. Whereas a tactical deal would be maybe a few $1 million and only take 3 to 9 months. And we were surprised that pharma companies were really willing to do these big, expensive, long-term deals as their first major deals in the digital therapeutic marketplace. So we looked at our platform. We have what we call a digital therapeutic platform. And the question for us has always been, with all these different therapies that we have on this platform, what are the best channels to the patient? And how do we capture the patient in their journey, as they're always in a different place in the journey? So after we started the direct-to-consumer business, we then began to explore enterprise opportunities with large payers and large employers. So today we have 4 of the 5 largest payers in the United States as customers, and we have many of the largest employers in the United States as customers. And this is focused on what we call the meta condition, which is anxiety and depression, as well as general chronic disease. What we saw with pharma is the opportunity to create a Happify specialty digital therapeutic business that would deal with all mental disorders as well as specific diseases, where pharma could be a channel through their patient support programs with what we call a DTX, as well as a channel directly to physicians through what we call a PDT, or prescription digital therapy. And then along the journey, we realized we still needed to have a direct consumer business, which we now call COPA. So what this allows us to do is to play across the entire continuum of care with patients. So we can work with the areas of wellness and prevention, diagnosis, treatment, monitoring and management, as well as referral and coordination, where each one of our 3 businesses, Happify Enterprise with the employer health plan, can do so. We can take the business that I lead, which is the Happify Specialty DTX, and play across all these different points in the care continuum. And then the direct consumer business can do the same. So what this means is we have 3 businesses. COPA, which goes to Facebook, Instagram, other digital media. It finds people with specific chronic conditions that are very high acuity in nature, but we're going after consumers directly. We bring them to our digital care delivery solutions around specific diseases. Our first one we launched last year was for psoriasis. We're looking at other disorders as well. And from that care delivery solution, they can not only get advice and counsel and community and experts and access to physicians, but they can also get access to specific types of therapies. They can get a free version of Happify, they can get a pharma, RX or OTC products, and they can also get access to prescription digital therapeutics. And each type of product has different revenue models associated with it. We then have our enterprise business. We go to employers and health plans directly. We focus on broad populations of employees and members, but these will also have high acuity diseases. Therefore, those people can also be referred into COPA to get digital care delivery solutions as well. And there we're providing a general mental health DTX and a general chronic disease DTX with a number of different revenue models, PEPM, PMPM, case rate utilization. And then we have my business, which is the specialty DTX business, where we work with pharma companies to offer products through their patient support programs for high acuity chronic diseases. We then also have prescription digital therapeutics we can partner with the pharma companies on to go after individual patients through physicians. And there, most of these patients will have a need for some sort of digital care delivery solution, which they can get access to through COPA. And then we provide a disease-specific DTX product through the patient support program and disease-specific PDTs through healthcare professionals. And there's different revenue models associated with these. And then this represents the access that patients get to both DTX as well as RX therapeutic solutions. So what we find is with this portfolio of products, we have COPA, which is very tactical. It's about how do pharma companies make more money by selling the drugs they already have. We have DTX, which is providing a wellness solution for pharma companies to offer their patients through a patient support program. We have an additional form of DTX, which is a DTX that is very disease specific that goes beyond just mental health, but also addresses the physical symptoms of the disease that pharma companies treating. We have PDTs, which are prescription digital therapeutics, FDA cleared. They would also, in other jurisdictions, have CE marks that can be prescribed by healthcare professionals to patients. And then there's 505(b)(2) and 505(b)(1), which is where you really combine the digital therapy with the prescription digital therapeutic to provide a much more comprehensive solution that can be branded around the pharmaceutical companies' brands and distributed through their sales forces as well. So as we look at this, we use this metaphor of crawl, walk, run, fly, where what we'll do with most pharma companies is the crawl is where we'll work with them for 2 to 4 months on a proof of concept pilot. We'll focus on mental health specific, but we'll target their disease and demonstrate that we can identify, activate, and engage patients in their disease area of focus with the mental health solution that we already have, because mental health issues are comorbid with 50 to 75% of their patients. After success in the crawl, we then move on to walk. And through a walk, we can provide a solution that enables patients to better manage the symptoms of their disease. It takes us 6 to 9 months to create this product. That's what the walk is. It's creating the digital therapy that they would offer through a patient support program. The run is then offering that product to their patients as the first version of a digital therapy for them to experiment with, to see how patients like digital therapies, how they use digital therapies. And the fly is then to create a prescription digital therapeutic that can treat the symptoms of a disease. And this is a more highly regulated, the most efficacious version of the product out there. And by so doing, what we do is we build off of the crawl and the walk to develop over 6 to 9 months the run, and then over 18 to 24 additional months to take it to the fly stage. And as we do so, we increase the clinical value as we increase the regulatory status and claim to the product. And so when we approach a pharma company, we'll do a crawl initially, demonstrate efficacy. We'll then spend 6 months to get a COPA stood up to help them find patients for their existing drugs. We then will develop a Happify DTX product that will address the disease condition that they're focused on. We'll launch that and give them experience with a digital therapeutic to then prepare the way for them to do a prescription digital therapeutic, which takes the longest amount of time, is the most expensive, and represents that final level of risk in digital therapeutics for pharma companies to then develop as a new source of revenue with a new type of product that combines both the digital and the physical elements of the disease into one product. So that's how Happify works with pharma companies to bring digital therapeutics to market in a very gradual way that enables them to take incremental risk to eventually get to where we think they all want to be, is on that strategic end of the continuum to deliver that value to patients. Thank you.
Thank you, Chris. Sadly, as you all may have noticed, Chris couldn't be with us today live, but he wanted me to pass on the message that he would be more than happy to answer any questions that you may have. And you can find his contact info on the participants page. Next, as the moderator of our second panel for the track, it's my pleasure to introduce to you Eugene Borukovich, a serial intra and entrepreneur, chairman and COO of Your Coach Health, an expert in digital health. Welcome, Eugene.
For those of you who are just joining us inside the DTX track, room 6, welcome. So my name is Eugene Borukovich, and I am co-founder and CEO of Your Coach Health, also serial intra and entrepreneur who's gone through all of the parts of the ecosystem, or most of them, in the healthcare space, and back into the entrepreneurial world. And I'm honored to moderate this esteemed panel. And one of the topics, as we've been setting the stage, throughout the day on DTX, kind of what it is, et cetera, is reaching patients and health consumers at scale, which, as I've always been saying, the technology is there just because it's there, unless you're actually touching human beings with it, and the human beings are touching it and using it, and it's a benefit, then it becomes kind of useless. So I'm going to definitely enjoy this panel. So that's me. I'm gonna be a little bit of the lazy host, and I'll have every individual of the participants introduce themselves, and I'll kind of guide you along. Let's start with Ayala, please. Yourself and a little bit of what your company does within a minute or so. Let's do it startup style.
Sure. So I'm Ayala Blia, I'm the CEO of Sivan Innovation, and we developed MoveCare. MoveCare, which is the first digital therapy that is reimbursed in France and prescribed by oncologists for patients with cancer. So it's a major innovation because MoveCare proved to improve overall survival and quality of life for patients with cancer. It's the first time that a digital therapy proved overall survival improvement. And the way it works is very simple. It's a simple questionnaire sent to a patient on a weekly basis. And then there is an algorithm that analyzes the answers to the questions of the patient. And if it detects an anomaly, a complication, or a relapse, it sends an alert to the doctor that can intervene quicker. And in 2 seconds, how it's possible to improve like that overall survival is also very simple. It's a patient with cancer usually has a scanner every 6 months or 3 months. And in between, he waits very anxiously to the next scanner. But because the relapse does not occur the day of the scanner, if he has symptoms, he stays home with the symptoms until the next scanner. And by the time we detect the relapse, it's too late to give an optimal treatment. This is what MoveCare about. Detect at the right time, earlier the relapse, and give the best treatment, the optimal treatment at the right time, and therefore improve survival.
Thank you very much. Let's move on to Rich, please.
Hi, everyone. So as Eugene said, I'm Rich Westman. I'm the CEO and founder of workplace wellbeing company Kaidu. We support employers to keep their teams healthy, engaged, and connected, which, as you can imagine, with the advent of remote working and the pandemic, has been super important recently. The program itself is used by companies large and small across the world, including the NHS and their employees here in the UK. And actually, the company itself is part funded by the NHS, which is where we're a little bit different in that we're invested into by University Hospitals Birmingham through their partnership with the Academic Health Science Networks. So great to be here and looking forward to the session.
Excellent. Charlotte, please, next.
Hi, everyone. I'm Charlotte Lee, and I am the UK Director for Big Health. We're a digital therapeutics company, and our mission is to help millions back to good mental health. As for me, I speak 3 languages, so I speak doctor, consulting, and digital health. Cut a long story short, I've kind of been around the houses within the NHS. I ended up being really interested in how you would create change at scale using digital innovation. So I ended up in the world of HSNs, supported the development of digital health accelerators before coming into Big Health to lead our UK mission. Big Health has 2 products, Sleepio and Daylight. Sleepio is a digital therapeutic to treat insomnia, and Daylight is a digital therapeutic to treat anxiety.
Excellent. And last but definitely not least, Anish.
Hi, everyone. Thank you, Eugene. I'm Anish. A month ago, I joined Biogen to head a new area, which is called Neurotech and Open Innovation. Half of it, I know what the job is. Half of it, I'm still defining. So I'll have a better story about it in a month or so. I've been within digital health, or let's say within digital and pharma for the last 10 years in different disciplines, mainly starting with the, let's say, equipping the commercial field force teams in order to do promotion with these things, but moved quickly along to mobile-based solutions that could be used within MS, within psoriasis, within respiratory diseases. And then my last gig, I would say, at Sanofi, where I could full-fledgedly work on DTX solution and had an opportunity to work within different therapeutic areas within cardiovascular and also neurosciences. And I'm really happy to be here with this panel.
Awesome. And you know what, let's stick right here with pharma. And I think for those who do know me, as me coming out of pharma, I always kind of joked around that DTX and pharma are somewhat of frenemies, right? They weren't sure if they need to be friends or enemies, and how do you play together or not. But I've also seen, I would say, especially, some of the silver linings around where we're going through as a society now. I think the pharmaceutical companies are certainly engaging much more and also have that larger reach, right, from a population perspective. So whether it's in your previous role, or I know you're it's still defining the other one, but I think, probably anchoring onto some of your other experience, I'd love to hear a little bit of that, I'd say, frenemy discussion concept, but then secondarily, as lots of DTX companies are pitching to pharma, what's some of the good examples that you've seen reaching these patients at scale?
Right. I think from a collaboration perspective within health tech and pharma, I think the honest answer would be we are yet to see a solution that has reached a scale, but there have been positive attempts, right? So I think some of the not just experimentation, but some of the launches that have happened, that Happify has done, I think that has reached like good, fruitful outcomes. And kudos to Ofer, Chris, and the team for doing that. When you look at Nuvo Air with Lorenzo, and what they've accomplished on launching products with a pharma company, or if you look at it from HCO's perspective as well, if you take pharma out of it, but look at hospital administration, they've done some amazing work as well when it comes to prescription-based therapeutics. So I think I think there's good learnings over there, which has at least given some perspective from a go-to-market perspective, from a regulatory perspective, from a potential business model perspective, how can this develop in a partnership with a pharma company? I think that's the phase we are in right now. But rapidly, if you think about it in terms of diagnostic or even pre-diagnostic screening solutions, I see a big potential and a lot of movement happening within that space as we speak. And those are the ones I think that will reach scale. Because it's not necessary at that point that you're looking at some sort of a regulated medical device grade solution. It can be a much more lighter version of it. So yeah, I'm looking forward to those.
Excellent. So let's, and maybe I'm just connecting some dots with your previous employer being in France. So I'm going to jump over to Ayala. I know that the journey was not easy, I'm sure, right? Because I think, especially from a regulatory perspective, if we wind back a number of years back, most people didn't know how to spell a DTX, right? And not, furthermore, how do you regulate it? How do you price it? So kudos on getting one of, if not the first product at DTX reimbursable in France. Can you talk a little bit about the combination of what that journey was like, right? And even the timelines, and what did you need to get it done in France? And then the second part is then you're focused on oncology today. How did you reach patients through what channels and at what scale, right?
Sure. So to was indeed a very difficult journey, a long journey, yet an exciting one, especially that we are the first one to be reimbursed today. Everything starts to get the reimbursement with very strong clinical proof. So even before we even thought like to approach the French ministry to get the reimbursement, there is 7 years of research and development. We started our clinical studies in 2012. So we had feasibility studies, prospective studies, and then a big clinical trial, phase 3, randomized multicentric study. And only because we had these very strong results, we were able to first submit a file for reimbursement in France. And I truly believe when we first submitted the file for reimbursement in 2018, the most important was to demonstrate our proof. And we had a solid improvement of 7.6 months in overall survival. To give you an idea, the overall survival for patients with lung cancer is only 18% at 5 years. And it's if you take immunotherapy, like Opdivo, Keytruda, very strong drugs, it only gives a couple months of overall survival. So it was the first step. We came with our strong and solid proof. But for the inside story, at first we didn't get the approval of the HAS. We got a negative answer. And we said, okay, we are not going to give up. As you said, a couple years ago, nobody knew how to pronounce DTX. So it was, we knew we had to explain it. We requested an audition. And during the audition, it was really the opportunity to explain, to clarify, also to dig into the clinical studies, the results. What was very different with MoveCare is that we did it like if it was a drug, like a comparative study with 2 arms, one with MoveCare, one without MoveCare, and then we compared. And then we were able to prove that a patient followed with MoveCare had his survival improved by 7.6 months. Also, during the audition, we were lucky enough to have some doctor of MoveCare who were convinced user who came with us, like Dr. Alain Livartowski from the Institute Curie, for example, and it really made a difference for the health ministry. So this was the first major part of the journey to get the recognition from the health ministry of this significant clinical positive impact for the patient of MoveCare. So we got the ASA 3 from the HLS. It's a very strong ASA. Again, there is no other medical device with ASA 3 in France. To give a reference, like for example, you have Opdivo has an ASA 3. So it's quite high level. And it was based on the recognition of the HLS of the strong therapeutic interest of MoveCare and also of the public interest of MoveCare. And then we come to the second step of this long journey. So once we got this recognition, we had to go to the negotiation of the price. Something I didn't say is that after the audition, we had a negative answer, but after the audition, we got a massive yes. I think it's important to know that because it shows how much the negative answer came from a non-understanding, because it's we are so not familiar with the way of treating
it was easier to say no than say yes, basically.
Exactly. Yes. Kind of, like when you don't know, when you don't really understand what it is about, yes, it's easier to say no. But once they really understood, it was a massive yes. So it was great. And then we came to the negotiation with the steps. So this is the government body in France that decides the price. And it was very difficult also because we didn't have any referential to compare us to. So we had really to imagine a way to fix a price, what is worth MoveCare. So of course, in the discussion, the most important thing was the overall survival improvement. So the benefits for the patient. Also, we proved the quality of life. So it's also very important because the patients are very anxious from scanner to scanner. And with MoveCare, they really feel closer from the doctor and it improves the quality of life. So it was the most important thing to fix the price, but also beyond that aspect, we also had to show some medico-economic evidence for MoveCare. So we had done some medico-economic analysis, and we proved that with MoveCare follow-up, you can save money. So there is a real interest for the public insurance. We proved that you have less hospitalization in emergency, you have less transportation costs by 35%. And overall, there is like a strong gain for the insurance. And more than everything, maybe, yes, when you think about a drug like Opdivo, Keytruda, or any immunotherapy, and you know how much it's expensive, and very often, because you don't give it at the right time, it does not have the optimal effect. And here with a marginal cost, I want to say, thanks to MoveCare, because you can give the treatment at the right time, you optimize the resources. And I think it was also something very important to get the price that you got.
So Ayala, just as a follow-up and maybe switching gears to kind of the patients at large and reaching, if you can disclose how many patients are using MoveCare and how did you get to the point of that, I'll say, distribution, and then I'll have another follow-up question to the whole team later, but yeah.
So today we have, since it was commercialized, altogether we had 400 patients using MoveCare, but in real life, since it's commercialized, so since September, we have 120 patients using MoveCare. For the patient, it's a great tool. It really helps them. They almost never say no, because for them, it's kind of like some testimonial of patients. They tell us that they are waiting for the Monday morning when they fill the questionnaire, because unless you are a VIP patient, you don't have the number of your doctor. So for the patient, it's quite easy to convince them. It's a way to make them less anxious, closer from their medical team. Now, the real challenge is from the doctor side. For the doctor side, it's a completely different way of treating the patient. So we really need to go hospital by hospital, doctor by doctor, and we really need to implement this change of paradigm. It's a different way to do it. And the doctors are already used to a working process. They already have their way to treat their patients. They see a lot of patients, 20, 30 patients per day. So they are scared that it's going to take some time. They are scared that it's going to be just not the right way.
And I guess even from the perspective of having a patient take a pill or an injection, now there's a technology piece that probably some lack of awareness to how to use it, how do you prescribe it, how do you monitor it, right?
Absolutely. So there is this first reaction, I'm not digital, I'm not a techie, I'm not that. And we need to explain to them it's super simple to use. It's very intuitive, and at the end of the day, it really makes their work much more efficient, because it gives them a full picture of the patient symptom evolution. It's a dynamic analysis, so it really helps them even during the medical visit to give a better diagnostic. But also today, for everyone, we have the coronavirus, and with this situation where the patient cannot come to the doctor, it's just a fantastic tool to be able to say, okay, you need to come. And if you are healthy, you don't need to come. So we need to do this triage, to do this decision. It's really powerful. And slowly the doctor understands that. What is yet something that I realized that the doctor is very important for the doctor is the clinical proof. So this is something that really helps us in the field. Meaning that if you don't have clinical evidence, I don't think that a doctor would really listen to you. But usually we have a lot of doors opened because of the clinical evidence.
Perfect. Thank you. Let's hop over to you, Charlotte. I met Peter years and years ago, and it's interesting that Ayala was talking about 7-8 years, right? And everybody kind of talks about, well, molecule is 10 to 12 years and 2.5 billion, but with digital technologies, we can move quicker. I mean, it's been, I don't want to speak, you can speak to when Sleepio / Big Health was born, but it's been close to a decade now, right? And I remember the first announcement of Sleepio at the time being distributed through Boots, right? But you guys came a long way. So I'd love to hear a little bit of, if you can discuss some numbers, great, but just how do you reach the masses starting in UK back in the day and then going to US and globally? So wherever you want to focus on it, but journey.
Yeah, absolutely. And just to make you feel really old, I had just started med school when Sleepio got announced and launched. Sorry for that.
I'm 19, so I don't know what you're talking about. But
like, all I can say is that Big Health started 10 years too early for the NHS. So just to give you a bit of background, I've been with Big Health for the last year and a half. And my gosh, how much has changed in the last year and a half. I remember when I sat down with Matt Gould and I asked him, do you think a digital therapeutic will ever be reimbursed nationally by the NHS? And he said, you know, at the time, sort of brand new chief exec of NHSX, he was like, no, honey. He didn't say honey, but he said no. And I was like, okay, well, I'm going to go out there and I'm going to prove you wrong. So we really tried. I'm going to talk a little bit more about the UK and then I'll touch upon the US perhaps in the latter part. But let's just say that since the coronavirus, that has absolutely like blown up our business. Within the last 8 months, we've reached 40,000 people registered.
blown up in a positive way, by the way.
In a positive way. I only ever use these adjectives in a positive way. 40,000 people in 8 months. Over half of those 21 to 22,000 people are in therapy, and that's not just for Sleepio. We also decided crazily to launch Daylight, our digital therapeutic for anxiety, around the same time. So we ended up, much to your timescales, publishing our first RCT for Daylight, showing that it was 71% effective in treating anxiety. Then we got picked up by NHS England as a partnership to provide Sleepio and Daylight at no cost to all, I think, over 3 million now. So it includes social care, health and social care staff. And then, 40,000 in 8 months, 20,000 in therapy, average recovery rates of 56% to 60%. And this is completely automated. So therapy is delivered without even a clinician involved in the process, which I thought was amazing. I wish we had a process in the UK like France or in Germany. Sleepio has 12 randomized control trials now, and it's been tested in over 8,000 participants. And I wish that I could say to you, we are on, a clear track to national reimbursement within the UK, but I think we're still, honestly, have quite a way to go in terms of learning from the experiences of Ayala, for example, in France and others within Germany. It's been amazing. And the way that we've been able to do it is, in a way, a combination of using your quite traditional B2C route. So getting out there, distributing to big populations through partnerships, but also in patient populations, we've been able to scale out education to primary care. So what I've tended to find is that there hasn't been a huge amount of resistance from GPs because we actually genuinely meet a need within primary care. A GP said to me today, for the last 2 weeks in his clinics, 100% of his patients have come to him with mental health problems. And that is unprecedented. You would normally expect round about now, for example, during winter, it'll be flu, coughs and colds, but no. A lot of them were young people with mental health issues. And he didn't want to be able to say to them, look, take a pill or go and see a psychologist, but you're going to have to wait 3 weeks. So this is where I think digital therapeutics, particularly in mental health, has a real kind of difference. And, I'm just glad that I'm able to do that with a company like Big Health.
Fantastic. And any comments on the US? I know I've seen some adoption in the pharmacy benefit manager space, being on the formulary. which obviously there's a big reach. So just any comments on that?
Yeah, so this is obviously Peter's baby. He managed to wrangle CVS and say, hey, look, we could have a partnership here where we could distribute Sleepio and Daylight through your PBM, and you'd also get paid. So we ended up partnering with the largest PBM within the US, and we are reimbursed every time someone uses our products, which is a fantastic system. In terms of the numbers, I think can I get back to you on that? I've got a data dashboard up.
No worries. I was just curious. I mean, it seems like a positive impact as well. Excellent. Well, let's jump over to Rich. I know you're not a true DTX per se, but I think as you guys are going towards the employers, I always joke around. Employees are also human beings, right? Not just employees. And some companies think of it that way, some don't. But I would love to hear a little bit of the adoption and how you guys are looking at DTXs within your environment as a company going towards the employers, but also in general, the adoption by employers for their employees of digital tools and technologies for health.
Yeah, so I think as a first point, just touching on where Charlotte started, we started thinking the NHS were going to procure our services, and I'd be on a beach by now. But rather than persevering, I suppose we did choose the privatized route, if you like, and got some early traction with that, and have sort of. It hasn't been easy, and again, as Charlotte said, it's probably taken us 3 or 4 years to get to where we are now. And in that time, the confidence, if you like, and the number of businesses that are adopting digital tools for their employee well-being, has certainly improved. Not just in the last sort of 8 to 10 months, where we've seen huge growth as in businesses looking for digital tools as ways of keeping their teams engaged, connected, continuing that positive health and well-being conversation when people aren't in offices anymore. So I think, things have changed for the positive. If you look at what employers used to do for their staff, it would be maybe an employee assistance program, which provided a very sort of reactive, if you like, offering to employees when they needed it. Now I think there's more recognition that prevention's better than cure. I hate to use that, but employers are seeing that too, and I think their confidence in digital technologies has been built by the likes of amazing companies like Big Health, like Unmind, who have shown that digital tools can be effective. And and just slowly over time, confidence is improving, and we're seeing that more and more companies are sort of looking to digital technology as a way of extending benefits to their team and keeping their team happy and healthy for longer. And just to touch on the types of businesses too, we've seen a shift in recent months. Really, traditionally workplace wellbeing was a luxury of enterprise level clients. It was something that you got if you worked at Deloitte or at KPMG or at HSBC. We're actually seeing now a lot more small and medium enterprise employers looking at workplace wellbeing as a way of sort of improving their employee value proposition. Making their company a more attractive place to work. And actually that leads to better retention of talent and that sort of stuff. So that's been really encouraging, particularly when 99% of people are employed in an SME. We're starting to get to more people, which is no bad thing at all. But there's always challenges, and there's a long way to go. There's always the engagement piece. It's all well and good a business adopting a piece of technology, but actually if their employees aren't using it or aren't aware that it's even there, that's one of the challenges we see. We can work with a client and they're fantastic, but actually if they don't promote it well, or it's not available through an intranet or whatever that may be, then that's not something we can do anything about. So long way to go, but I think the positives are that these digital programs provide data back to the business. That's data they maybe couldn't get their hands on before around the health and wellbeing needs of their team, the potential return on investment from these programs. And, that's data that traditionally they'd have to get through boring employee surveys, let's say, that no one wants to complete. So, we are adding value along the track somewhere. And I think as long as it's positioned in the right way, there's a lot of concerns that we've overcome in terms of employees being concerned that their employers using this to almost monitor their health and make rash business decisions, like a Big Brother style model. But it's just positioning it in a way where it's a benefit provided by the business, but actually the the decision to use it and thus to share data as part of it is with the individual employee themselves. And that's taken us a long way into this space.
Excellent. Now I'm going to do like a little bit of a fire round here where we can all either chime in. But as I've been thinking more and more around digital therapeutics, right, and they seem to be taking very much of a molecular path to market as well, right, just from, rigorous clinical validations and studies, pricing models and market access. But just like in the pills, and I personally hate that term of adherence, but there's been quite a lot of discussions on, adhering to pills, right? And non-adherent patients. How do you guys look at it from a DTX perspective? Because just because an app or a piece of technology or a reminder is there, that doesn't mean that people will actually use it. So again, we're running out of time. Unfortunately, we can talk for hours on this, but Charlotte raised her hand first. I'll go to you.
Yeah, I can jump on this. So obviously this is within the world of mental health. So take this with a pinch of salt. We define enrollment and adherence in relation to how it's currently conducted and assessed in the real world. So one such example is the Improving Access to Psychological Therapy service. It's national in England, and they look at adherence from when someone starts their second session of therapy. And that's what we've adopted because that is the market that we live in. Similarly, in other markets, for example, in the US, a psychologist might start billing after the first introductory session. So we would kind of mimic that. So in a way, we're distributed like a pill, but we are very much a healthcare service.
Perfect. Anybody else wants to chime in?
I can say something about MoveCare, yes, because I think it's the great thing about MoveCare is that the compliance rate is 85%. It was calculated. And again, because such a digital therapy, it's not like a pill. A pill, it does have a lot of side effects. So you don't want to take it. You want to put it in the garbage sometime because the side effects are very hard. But with MoveCare, with the digital therapy, with this follow-up, it gives you so much. It makes you feel closer again from the doctor. It makes you feel that you are less anxious, that you have a personalized care. And because of that, the compliance is not really an issue from the patient perspective. Even though I agree and you have to bill, also according to the compliance of the patient. And this is something great about software. You can track this compliance, not like a pill. But also with digital therapy, in fact, it's a way to improve the adherence of drugs. Like you give a drug and you have no idea of what the patient is doing with that. He can take it, he can put it in the garbage because of the toxicities and the side effect. And again, if you follow with a digital therapy like MoveCare, you can track this side effect and you can improve the observance, the adherence of the drug thanks to this follow-up. So in fact, it's kind of digital therapy that can help to increase the adherence of drugs, which is powerful. Yeah.
Perfect. Anish.
So Eugene, there are two parts to your question, right? Tricky boy. There's one which is in terms of adherence to, so how engaging your digital therapeutic solution or your digital solution is within the hands of the patient, and then how is it enough to actually treat you as a complete person? Those are two different level of conversations, right? The first one, in terms of adherence, for the longest time, even within
we only had 4 minutes. That's why I packed it into one. But go ahead.
So for the longest time, I thought adherence was a pharma made up thing, because you set the bar on how many times this pill or that injection is supposed to be taken, and then you measure adherence based on that. And then I was proven wrong on why exactly that is done, because there's a lot of clinical study and dosage requirements that are there. When it comes to digital therapeutic, right? So there's only one thing that I would disagree with Ayala, what she said in terms of the side effects. The main reason why a digital therapeutic is a digital therapeutic with the basic component of it being a medical device, which is covering for safety, is that we are able to show efficacy with that. Now, if you're not able to show efficacy with that, that's a side effect. That's maybe not a side effect, but that is not impactful enough. And if it creates it creates anxiety or any sort of let's say negative impact, that's a side effect that needs to be recorded, right? So that's one component you need to think about it. From that other piece, in terms of, is a digital therapeutic enough to actually capture all the comorbid conditions that a patient has? We are not there yet today. And that's a world that is, I think, a little bit bigger than digital therapeutic itself. It's more about when you go into remote care or personalized medications, and a digital therapeutic solution may act as one part of that ecosystem solution that could work in the treatment of a patient. I think we are yet to see on how this platform play is going to work out. And when you look at Big Health, for example, when you look at Kaya, when you look at these companies, they are moving towards a platform play because they have enough evidence to show this is how our software works as a drug in this context, right?
Agreed.
So I think the next couple of years, when platform perspective, will have much more data, much more information about comorbid conditions, and I see a lot of people accumulating that sort of data. I think that's when we'll have a much more
and we'll see for the financial crowd that's listening, we'll see probably many more SPACs, launching and merging a lot of companies across different therapeutic areas and pathways. So on that note, I wish we can continue because this is like an amazing crowd here, but we are out of time. I guess my short 10 seconds, not even, is that while tremendous impact has been made already in DTX and the reach to patients, we still got a long way to go. So I kudos to everyone that's driving a lot of these technologies and adoption. And thank you for the esteemed panel.
Thank you so much, Eugene. Thank you, guys.
Thank you.
Thanks for having
Bye.
me.
Thanks, everyone. Bye-bye.
Thank you so much, Eugene, and the panel. That was incredibly interesting, and I'm happy that a lot of great insights came out. It's my pleasure to announce, to reintroduce Annalena Lawrence. She's going to be moderating our second fire chat. So, Anna, on to you.
I'm super glad to be back. Welcome, Jonas. Very excited to have you. Let me intro you real fast. So Jonas is a co-founder and the US CEO of Kaya Health, where he has blueprinted their second product, the Kaya COPD solution. And he's also currently building out the US team, and they're leading the charge on the international market access and building out that business over there. So welcome.
Thank you very much for having me.
I asked this question in the other fireside chat. So while I have you, I want to ask you again as well. We were looking at COVID and how it's had tremendous efforts or impact on other digital health solutions such as telemed. So tell me, how was this year for Kaya? Do you have an idea? Was it great? Was it bad for DTX?
Yeah, thanks. I mean, so for us, Kaya as a team, obviously we were struggling with the same restrictions as everybody else. We had to switch into remote mode completely, and that was a really new experience for the team. More reflecting on the industry and DTX and demand, I think it's a really critical year. It will accelerate a lot of the things, and I have a couple of stats here for you. So for example, from February to March, we saw a 32% increase in signups. We saw a 69% increase in active users, and we saw a 154% increase in overall modules being completed in the app. So definitely, I think COVID is going to have a lasting effect on how people choose to consume medicine digitally. However, having said that, also, when the US started opening back up in May, of course, these numbers began leveling back down a little bit. But let's say people are getting much more used to just receive care digitally, or anything really, because of this special situation this year.
That's super crazy, those numbers. Even if they're leveling,
what's the outlook? What are the key next challenges maybe that you as a team and as a company are facing? I saw you have or recently had a great new funding round. So what are these things that will be your focus now?
Yeah, right. So, I mean, as alluded to just before, we do expect an explosion in demand. On the one hand, due to our unergonomic settings that workers were in while working from home, but also just postponing or skipping treatments, elective treatments, and this increased acceptance of consuming medicine through digital means. And at the same time, only 18% of employers in the US so far have a digital musculoskeletal solution, and it is the biggest cost bucket, or one of the biggest cost buckets for most of them. So we do see an explosion in demand that will be our main challenge, so to say, next year.
Exciting times ahead, I guess. Let me jump a little bit backwards. You build it saying patient first, digital second, and it's a very holistic approach, right? So can you tell me a little bit more about that and how you were able to focus on that patient or wove that into your product?
Yeah, absolutely. So I'll first answer the part around why we believe in the mind-body approach, and then talk about what we mean with patient first, digital second. So what we've seen in the traditional healthcare system about 5 years ago when Kaya was started is that it often doesn't work well for many people who live with a chronic condition, because the way it is designed, it's more a sick care system trying to treat and cure one episode of a disease with one episode of care, so to say. But all too often that is not really the case with chronic conditions such as chronic pain. So chronic pain patients have very frustrating experiences when they engage with the traditional healthcare system. And in many countries, because they end up cycling through the system, so to say, knowing that if they go see their doctor, they will, again and again, just get prescribed pain medication or a limited amount of physiotherapy sessions, which they already know that, are not going to help them from a past experience in a sustainable way. Those treatments, they do not really take into account the mental health and the behavioral health aspect of the condition. And pain is often exacerbated by stress, anxiety, depression, and vice versa, actually. And so that's why we believe a holistic treatment like multimodal pain therapy, sometimes it's called biopsychosocial rehabilitation in the literature, yields better results as it looks at the mind and body aspects, but it also does equip our users with knowledge to better self-manage their disease. And I mean, it's actually not just our opinion. There's a very, very solid and broad body of evidence around these interventions.
We spoke earlier at the event about developing digital therapeutics starting as something that digitized existing standards of care. And it's shifting now towards creating new standards. Like, where would you say Kaya lands on that? And you alluded to that a bit, but can you dive deeper on that a bit?
Yeah, absolutely. So maybe to answer the question of what do we mean with patient first, digital second, what we mean with this is that we don't completely reinvent the wheel. We take multidisciplinary rehabilitation interventions that already have a solid and broad body of evidence, such as multimodal pain therapy in pain or pulmonary rehabilitation for COPD patients. We digitize them and we deliver them through the modality of the smartphone. We then enhance them with technology and we rebuild the evidence around this digitized solution. So essentially that means an intervention that has been around for a long time with highest level evidence supporting its efficacy is what the patient gets. It just happens to be digital. Mm-hmm. It's not so much all about it being digital. It just happens that this particular modality is especially useful for these long-term chronic behavior health conditions.
So I saw there are some outcomes from a late study this year that shows outperformance of standard of care even. So how can you describe that this digital version of this existing standard of care, how has that turned into better outcomes, or what does digital enable to create this, so to speak?
Yeah, absolutely. So what we see is the digital modality just gives us certain elements that classically a healthcare professional wouldn't have. So, for example, when somebody does go into the inpatient setting and get treated with biopsychosocial rehabilitation or pulmonary rehabilitation, oftentimes, it's a 2 or 3 week intervention. People are in a clinic. They build these relationships with their healthcare professionals, and they get really, really good outcomes. So they go home. They feel empowered. But what all too often you see is that at the 3-month or at the 6-month follow up, many of these results just diminish again over time. And one of the reasons for that is that basically you're putting people into an environment where they have the ideal setting of making progress and better self-managing their condition and regularly exercising and so on. And then you rip them out of that environment and you put them into their previous environment at home. And so they start or they continue having the habits, or for example, be it a sedentary lifestyle that they had before, and they really struggle keeping up with the good habits that they maybe worked to build in the clinical setting. And with the digital modality, you have the big benefit that now you can nudge somebody on their smartphone with push messages. They can do very short training episodes, build them into their everyday life schedule. And so just the whole behavioral health aspect is much more convenient for somebody to do at home and to be more successful over a longer stretch of time.
Now, with this, you also have much deeper connection to patients. You follow them along much more. So you have also other data points than what we usually have, right? So can you tell me a bit more about the role of clinical evidence in the generation of the solution, but then also focus on growth or expansion of these solutions?
Yeah, so clinical evidence is critical, as otherwise reimbursement is not feasible. I know there's, in the US, but also in other places, there's obviously a lot of wellness solutions, and there's sort of a little bit of an overlap of these wellness solutions and then kind of management of chronic disease, all the way to really treating and making symptom-specific treatment claims. And we believe even if you commercialize through that wellness channel, or you're closer to the employer wanting to have healthier employees and less absentee days, clinical evidence is really, really crucial to be able to articulate your value in the market. And so that's why we always believed and very early on started running randomized controlled trials. One of those latest RTC is a cluster randomized RCT where we randomized at the primary care physician level. We had one intervention group that was given Kaya. Another control group was just followed within the healthcare system. So whatever the primary care physician prescribed, be it pain medication, be it physiotherapy, be it injections up to surgery, we basically followed these patients on the path. And what we saw was that actually the patients with the digital intervention had superior outcomes in terms of pain reduction, but they also had a big improvement in stress, anxiety, and depression, whereas the people who were cycling in the traditional healthcare system they actually saw a decrease, so a worsening in stress, anxiety, and depression.
That's incredible. Can you go a bit deeper on this path to like clinical studies, especially RCTs? It's usually not the first one you start with, right? So how was that path from the first pilot study, the outcomes gathered there, to where you are today, and the RCTs you're conducting, and also maybe how this digital component has helped conduct these studies?
Yeah. So I think depending on the indication that you're treating, and kind of the risk maybe that is involved, the risk in terms of safety with the treatment and the group that you're dealing with, you can take different approaches. And what we see right now in the digital therapeutics industry is that there's some companies, they take approach which is very close to what pharma is doing with molecules. Basically, you develop everything pre-market, and you go through different phases. You build meticulous clinical evidence, then you go through the regulatory approval process, and then you go to market. Some other companies which come more from a tech background oftentimes, and also are treating, are maybe a little bit closer to the wellness sector, especially if the treatment claims of, for example, chronic disease are more about managing the disease and not necessarily treating a specific symptom or trying to cure something. You can start with pilot studies relatively quickly, being able to show a low risk, show that people can successfully self-select into the solution, and then you can much more quickly go into the market, make it available to consumers, and then take basically that real world evidence that you're generating with those groups to build out or complement your clinical evidence that you have from prospective trials with long-term real world evidence, which is very, very important in these diseases, just because they relate back to what I mentioned earlier, the habits into long-term efficacy of a solution and the long-term success that people see with it. And especially in chronic conditions, oftentimes outcomes are measured also in literature with anamnestic questionnaires, with quality of life questionnaires. And these patient-reported outcomes are something that you can relatively easily record with these digital solutions.
Great. You already mentioned something, so I want to drill a bit deeper and shift the focus on patient access and how to get there, right? So I know, like, maybe you can tell us a bit more about the past go-to-market that you've had. How I know you're already working with insurances, reimbursed in Germany, etc. So tell us a bit about those direct-to-consumer successes, and also your first conversations with insurances and how that has gone over the last years.
Yeah, so basically, we very initially started partnering with a local health insurer and a local university, the Technical University of Munich, and that was actually a research project, a large scale research project, also funded by government to assess how a digital therapy like Kaya would or could be included in standard of care. Back then, that was for back pain, and so that led to the publication then of one of the studies that I mentioned earlier that demonstrated the feasibility of our back pain solution. We then were able to use this study and also certain observational real-world evidence results that we were looking at in parallel to demonstrate the feasibility of the solution. so we really had a hybrid approach where we were able to show on the, to a consumer on the individual level how they were progressing with their pain levels, because they logged those on every day. And at the same time, we were able to show that data on an aggregate level to the health insurers, which then led to them wanting to offer this to their members. And so then with a growing user base, and establishing partnerships with German insurers that pay for that therapy, first with selective contracts, that then helped to establish the technology in the existing pathway. And while in parallel offering that to consumers, while also sponsoring peer-reviewed randomized controlled trials, we were kind of able to use the different segments to amplify each other. And now, of course, the next goal would be to really just be a prescription digital therapeutic, where the legislation in the respective countries is developed for that, so that we really have a deep integration into the existing healthcare system, so that in the end, prescribers can actually offer the solution to people at no charge, at no cost, because they already know that they're actually going to save in the long term costs by offering that solution to their members.
On that specific switch, so to speak, or like shift that you're undergoing, like what are the key challenges you're facing to shift from a D2C to a prescription model now, and reimbursable then?
Yeah, I mean, there are two main challenges that we experienced in the past. One is the value provided and how to get paid for it. And the other one is providing easy and broad access to the solution. So the first one, the value provided. So at some point, it was clear that the value that our solution provides in terms of cost savings is much greater than what a user would be willing to pay out of pocket. And it is hard to sustain a business purely on B2C revenue, especially if you have that rigorous approach towards evidence. Clinical trials are not exactly cheap, and so it was hard to sustain the business purely on B2C revenue. Also, because some people they were not yet there of going to look on the App Store for a back pain treatment, and many people are still willing to spend only very little on their health, and rightly so in many healthcare systems where there's a clear role of the payer having to pay for it. So that's kind of why we always followed this hybrid model of on the one hand benefiting of the iterative approach that you can have on the consumer side of things, while still generating clinical and health economic evidence to pursue reimbursement from health insurance. And we did hope that we could have a B2C and a B2B solution next to each other on the market, but we were proven wrong, and we did have to focus then purely on B2B, so not to cannibalize our own business for the time being.
Was there any pushback or challenges specifically that you faced from these insurance companies when you shifted from D2C to their prescription model, and all the business model changes that came with that?
Yes and no. Yes, there was pushback because, so for example, the study I mentioned, there were payers also in part of that project, and they already had their interim results, and they probably already saw that they got a great deal with the first pricing, right? And it is a discussion that you have to have at some stage when you actually build the evidence around your solution. Maybe that's one of the main differences to the approach that I mentioned earlier, which is closer to pharma, where right at the start you only focus on generating the evidence in a closed setting, and only once you have that evidence and you know exactly, you know, the health economic consequences of your solution, then you go to market, and then you're not going to have the problem of having to renegotiate price, but you're being held back in the development of being very, very user centric. So yes, it did require a couple of conversations, but in the end, payers believe in the solution, and they saw the evidence, and they saw that it was very successful in their populations, and so we found a way to make these arrangements happen long term.
That's great. I mean, now you're focusing specifically on the US from your perspective, right? So I also want to ask, because I know it's quite different there, and employers are much more involved than they ever would be in Europe. What are key differentiations or differences, that you're seeing in commercializing Kaya Health over there?
Yeah, I think of course, the healthcare system runs in a very different way compared to many European countries, and even within Europe, you have vast differences. So there's key differences in commercialization and of course in regulatory as well. So due to the high prevalence of musculoskeletal solutions and large employers in the US being often carrying a large part of the risk of their population by having to pay insurance claims directly, it does make sense for them to deliver, or in general, to deliver this solution directly on a population level, because the employer in the US, who for many people directly pays their insurance, as mentioned, has a direct financial interest in the well-being of their employees. There are certain adaptations that are required for those employer-paid pathways. So you have to look a little bit different into how you deliver the solution.
What would be a key difference maybe in how you are different or look different in your delivery?
Yeah, so you have to imagine it's very different if you get your solution prescribed by a doctor while you go and see your doctor for an appointment, or it is your employer trying to convince you and trying to reach you that wants to provide you the solution. So marketing and engagement work are very, very different from a pure B2C play, or as mentioned, the prescription-based promotion and distribution. You need to work very closely with the employer. The employer needs to trust you that your communication plan is efficient, because attention of employees is a limited good, and you need to be able to show outcomes in their industry. You need to show it relatively quickly on their own accounts. They want their customer satisfaction, employee satisfaction is very, very important. So there's many more aspects than just the clinical outcome and kind of the health economic cost savings. There's also an indirect financial interest in having less workdays lost, higher productivity, and then especially employers that have a very costly workforce and want to keep turnover low. For them, it can actually be a main selling point that if they have a really good solution for their employees that they're happy with, it can make them also more sticky to the employer and more satisfied with the employer. And then I think another aspect is you're selling account by account versus going after broader national reimbursement or reimbursement by health plans, at least at the moment, because that is how legislation works right now.
Yeah. Shifting back to Europe a bit, and I want to look at, we focus a lot on the MSK here, like you also do COPD, right? So Maybe two questions here. I saw just now the partnership announced that you signed with Chiesi. So I would love to learn, of course, a little bit more, especially since we just spoke about the pharma's partnership role in the last panel, but then also like that move into COPD. How are they similar? How are they different? And this indication change that's very different for pharma products. How does that look like for a digital therapeutic?
Yeah, great question. So COPD and chronic pain may seem very different indications, and they are, but in a certain aspect, they are also similar in how you can approach treating them. So both are chronic conditions. In both conditions, it's about managing the conditions and not curing the conditions necessarily. Especially with COPD, it is an incurable disease. Both have good mind-body therapies, which have high-grade evidence around their effectiveness. But these therapies are expensive. They are being done in the inpatient setting, and therefore they have an accessibility problem. Being usually delivered in a clinic, that makes it for the payer only possible to reimburse it for the most downstream and late stage patients that then get access, and while more upstream patients could really benefit a lot from the treatment already as well. Then the physical setting itself can sometimes limit certain people to get access to it that live in rural areas, or even if it's in an outpatient setting that have to take the car, drive to the other side of the city with their oxygen concentrator and don't feel comfortable doing that. So that whole behavioral aspect and that aspect of wanting to be more sustainable with an intervention and making it easier for somebody to be successful in the long term is something that is very, very similar in COPD. And we're not trying to replace the few slots of inpatient pulmonary rehab that there are. Not at all. We're really trying to just make them more accessible, because in some countries, the seats that you have or the beds that you have for pulmonary rehabilitation in a given year is enough for treating 0.5 to 1% of all COPD patients, which is just, even if you throw all the best people at it, you throw a lot of money at it, maybe you get that capacity over a couple of years to 2% maximum. And so we're really trying to work on that accessibility problem. And so Chiesi, for those territories where we do see a prescription pathway forming for national reimbursement, it is absolutely ideal to work with a life science partner. And we're very thrilled to have found with Chiesi a very innovative partner on this mission to create more scalable access to these therapies for patients suffering from COPD. And especially with COPD, the healthcare professional space plays an even more important role. We really want to make sure that we integrate the solution in the current existing healthcare system. And it's ideal to have a pharma partner, a life science partner there. And by the way, Chiesi has also won prizes for their sustainable and ethical way of doing business. They're very innovative, and this is an important project for them as well. So we're very proud that we found this partner.
Congratulations. You mentioned something about integrating it into the healthcare system, right? And into the ecosystem. How is is there interaction with Chiesi's portfolio of pharmacological interventions in this space, or how does that look?
Yeah, great question. No, in this case, we're not actually dealing with a bundle of digital therapeutics and a drug. It is a partnership that is focused on market access and distribution, promotion amongst healthcare professionals, and it is focused purely on the software only digital therapeutic. So in that sense, also kudos to Chiesi to make that step and believe in this digital only solution and go into this very new field.
Perfect. I want to be wary to leave some time for questions. So thank you so much. It's been a pleasure, and let's see what came in.
Absolutely, yeah.
So nice to have you here to answer a few questions live. I want to directly dive in with the one on the chat, the last one here. So you mentioned consumers aren't really going to the App Store to find like back pain management. So how did you make your audience or your patients aware of the product, and what partners were strong advocates for it?
So it depends on the market and the exact segment. So first, we did have a consumer directed approach, and so we did run campaigns, online campaigns, as well as print campaigns out of home. But nowadays, we're working more, for example, in the US with benefits departments, HR departments, on a communication plan that works for them and their ecosystem of solutions that they have integrated. And the same with health plans. So we're using all kinds of channels where people would get informed about their health and where we can reach them and where they're in the right mindset to use the product.
You already mentioned it, and one of the questions we got in is also about the difference to the US market, especially since it's an employer-paid one. So what did you have to change or adapt mostly to reach this new ecosystem, or how does it differ in what they ask of a DTX?
Yeah, so I think the important distinction there, again, is since we are making mainly self-management treatment claims, oftentimes we are sold as a wellness program still directly to an employer. And what is different there is you have a different buyer. You have these employers, it's a very crowded space already, these wellness solutions. And so even though we have a much more solid body of evidence maybe than many of the traditional wellness solutions, you're dealing with very sophisticated consultants that are in this advisory role to the HR departments. And so member engagement marketing is very, very important. Being able to show good engagement, being able to show good satisfaction along with health economics and clinical evidence.
Right. I want to build on that. That's my own question. Building on that question that we just had, is there a difference in patients' willingness to pay out of pocket between those markets? I mean, you mentioned in our fireside before that there's a strong payer role in some of them. How do you feel that on that end?
Yeah, so in both of these geographies, in Europe and in the US, there is a big gap between value created and willingness to pay out of pocket for healthcare. I think that's just generally the case. In the US, people are willing to pay more out of pocket. If we're talking about the pure dollar amount, you would find a bigger market here that is willing to pay more. But it's still a big gap between the cost savings that we're actually producing and what somebody would be willing to pay out of pocket. And so that's why also here our goal is really to provide broad access to our solution through employers and health plans, which are the classical payers in the healthcare system over here.
Great. I'll end this. This is the perfect question to end the day. So we saw in the chat this question, you are a pioneer DTX company, but digital therapeutics as a category is still quite new. And we spoke a lot about that in the earlier panel and the fireside chat earlier today. So also, have been easier for you guys to access clients or partners since they were recognized as such, or has it been the different or reverse?
Yeah, shout out to Aline. Thanks for the question. So, sorry, boring answer. It depends on the geography and the market segment. And also, I think I have a very biased lens, potentially, because as we grew as a company, general awareness was growing too in buyers and partners over the last couple of years. So I think there's certainly less doubt about the value that digital therapeutics can provide, and buyers and partners also know how to better evaluate them. But while there's more general awareness, I think the barriers still remain the same. So evidence for engagement, customer satisfaction is very important. Clinical evidence, and building a strong health economic value foundation is just as important, or has become even more important. And I think as companies build that out, they will find it easier to access clients and partners. But at the same time, if you don't check all of these boxes yet, I think the market certainly has become much more crowded, especially in the section, making mostly wellness claims that I mentioned earlier in the U.S. employer market. There's definitely a lot of crowds building in with point solutions that I think are going to consolidate more into multi-disease ecosystems and platforms over the next 5 years, I would imagine.
Perfect. Thank you so much. I'll close it off. Thanks so much for your time, for being here, and I'll hand it back to Valentina.
Thanks, everybody. Thanks.
Thank you, Anna. Thank you, Jonas, for being with us today. Wow, we've had such an amazing day, such an amazing track. I hope all of you have enjoyed it as much as I did. I would like to invite all of our participants to check the poll to answer a couple of questions that we started the day thinking of. So we would really love your inputs and to know what are your thoughts after hearing all this amazing panelists. For some people, if it's not working, you may need to refresh the page. Our tech producer just advised us on that. So just as a closing words, I would like to thank Giant, thank all our panelists, thank Anna-Lena for curating this amazing track, and hope the conversation continues to grow, insights continue to be built up, and next year and in the future, we can see more really cool initiatives like the one we saw today. Thank you very much, everybody.